Good morning, everyone. Now, Mr. McIntosh.
Our witness today is Dr. Jennifer Armstrong, the Medical Director of NHS Greater Glasgow.
Good morning, Dr. Armstrong. Now, as you're aware, you're about to be asked questions by Mr. McIntosh, who's sitting opposite you. But first, I understand you're willing to take the oath.
Yes.
Sitting where you are, could I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth, and nothing but the
and
truth.
nothing but the truth.
Thank you, Dr. Armstrong. Now, we've scheduled your evidence for the day, and it may take all of the day. We will take a break at 11:30 or so for coffee, but if at any stage, either the morning or the afternoon, you wish to take a break, just give me an indication and we will break. No, Mr. McIntosh.
Thank you, my lord. Dr. Armstrong, I wonder if I can take your full name and your current occupation.
Jennifer Louise Armstrong, and I'm Medical Director of Greater Glasgow and Clyde.
Now, you produced a statement for the inquiry.
Yes.
Are you willing to adopt that as part of your evidence?
Yes.
Thank you. Could I just check a couple of things about your professional background, just for clarity? What was your practice area before you became Medical Director in 2012?
I was a consultant in public health medicine.
Thank you. Now, if we can go to your statement on page 376, where you produced your CV at Appendix D. I want to just understand a little bit more about the description you've given of your current role at the bottom of this page. And you've described yourself as your role including developing GGC clinical strategy, ensuring patient safety, driving forward quality improvement, financial, staff, professional governance, and ensuring there's a robust clinical governance system in place. And I just wondered if you could explain, how do you see your role, particularly in respect of ensuring patient safety?
Yeah, I mean, maybe if I could give you a bit more description about my role. So, Greater Glasgow and Clyde is at 4.4 billion, and it employs a staff of about 41,000. And my role is, first of all, the professional lead for around 4,000 senior doctors, and we train around 2,000 junior doctors a year. I've got about 3 different areas, so I'm one of the non-exec directors on the board, and I give clinical advice on the board. In terms of the corporate management team, I'm a member of the corporate management team, which has 6 directors who all do the primary care and mental health, as well as the acute chief operating officer, who does all of the acute sector, and then headed up by the chief executive. And then my third role is really around, I have a number of teams that report into me. So one of them is the clinical and governance team. The other one would be the medical education team, the pharmacy team, as well as the planning and strategic team. I also used to be the HEI exec lead for Greater Glasgow and Clyde from 2012 to 2020. So that's really my role, and it spans right across acute, mental health, and also primary care, so the whole health board.
Yes, I just wanted to understand how you would explain to a lay audience, if you can explain it briefly, how you see, what part of your role or what you do through your working months, as it were. How do you ensure patient safety? What is it that you actually do to ensure patient safety?
I would say there's a range of things. So one of is the clinical governance team, the support unit. They will produce policies. They'll also support all the teams across the board in terms of ensuring that there are good processes and structures in place for patient safety. In terms of my role for professional leadership, I also will put forward doctors for revalidation every 5 years. So it's making sure that the medical professionals, indeed other professionals that we have in place, are properly trained. But it's also looking at the governance structure for the board. So it's looking at the board clinical governance, and we have 3 pillars underneath that. One is mental health, primary care, and acute. And it's also looking that we've got proper processes in place, we've got the proper staffing in place in order for us to ensure patient safety. And really patient safety, I think, is the heart of everything that we do.
Thank you. I want to just look a little bit at the reporting structure that existed for infection prevention and control in the period from 2015 to the end of 2019.
Yeah.
Now, I'm going to try and set out what I think I understand, and I'd like you to tell me what I've got wrong. So, firstly, in that period, you were the healthcare acquired infection lead, and that's right?
Yeah, it's HEI executive lead, and it's a common title across all the health boards.
Yes. So, what do you see? What did you see when you had that role? Was the role? What did you have? What did you need to do?
Well, the HEI exec lead is it's at a corporate position, so I would chair the Board Infection Control Committee. One of my main functions was also to make sure that the board was fully aware of infection control issues. The Board Infection Control Committee as well looks at all of the policies coming in, mainly from Scottish Government and others, and make sure that we consistently approach policy across the whole board area, because it's got to be consistent, as well as the infection control manager would report directly to me, so I would provide leadership to the infection control team.
Well, I want to look at the team next.
Yeah.
So, for the period up until March 2019, I understand the infection control manager was Mr. Walsh.
That's correct.
And then from then until a date later in then it was Sandra Devine, I understand.
That's correct.
And did it then become Marion Bain? Have I got that right, or am I misunderstanding?
Well, no, Marion Bain, there was a new post created around about January 2020, which was called the Director of Infection Prevention and Control, and that was part of the escalation process that Scottish Government put in place. So Marion Bain held that for a couple of months, and then that was taken over by Professor Angela Wallace.
And so where did Marion Bain sit in the system? Did she sit between the infection control manager and you, or one side, or how?
No, she took the responsibilities of the HEI executive lead. So she had a role with Scottish Government, and she also reported, I think, directly to the Chief Executive, and Sandra Devine would have reported in to her.
Right. And then within the infection control team itself, there would then be two professionals. Initially, it would be a lead infection control nurse, Sandra McNamee, then Devine. You're nodding now. There's the transcript person.
Sorry.
We have to remember them. And that job title changed over time.
Just if I could take a step back, because it's actually very, very common. So Greater Glasgow and Clyde is a general management structure. And what that means is that each level there is a manager, and the manager will have a nurse and a doctor, a senior nurse and a senior doctor. So if you look at something like the Chief Officer for Acute, they will have a senior, so you've met them, the Deputy Medical Directors and a Deputy Nurse Director, and they'll have a team of people. And they will be responsible for all of the governance, all of the finance, and all of the staffing. And that then goes down to the divisions. So with infection control, it's the same thing. So there will be a senior manager, and there will also be a senior nurse that will report into the manager as well. So there is a nurse and there's a manager who will run infection control.
So the manager has two people reporting to them in terms of managerial. One is the nurse, lead nurse,
Yes.
and the other is the lead doctor.
Yes, correct.
And I don't know whether you can help us just from your perspective. Ms. Devine's job description changed. She became an associate nurse director. What was going on there? Or have I misunderstood?
I'm not sure that did change. So when I was there, her position didn't change until she became the acting infection control manager. And then after that, she's become the Director of Infection and Prevention and Control laterally. So that was what happened.
And then we have a lead infection control doctor.
Yes.
And am I right in thinking that pretty much consistently through 15 towards the end of 19, half their sessions were infection control and half their sessions were microbiology?
It did vary, but yes. I mean,
in broad terms?
Yeah, in broad terms, the infection control manager would manage the lead infection control doctor, and they would organise the sessions between them. But in broad terms, you're correct.
And then there would be a number of sector ICDs around the health board with a couple, maybe sometimes a few more sessions within their job plans.
Yes, so there were teams right across. I think there were about 5 teams, and they would have a sector ICD, but there would also be a lead nurse as well for each of the sectors.
So we for example met in the context of the Queen Elizabeth. In its early years, we met Professor Williams and then Dr. Inkster as lead ICD.
Yes, correct.
And we met Ms. Pritchard and Ms. Ioannidis as lead nurse. And we met lead nurses infection control nurses within the 2 hospitals within the Queen Elizabeth site.
Great.
It's very helpful, just put it in context. What I want to do is turn to your involvement, or rather, I appreciate your non-involvement, but it's the context of it, in the procurement of the hospital. Now, you've been very clear in your statement that you weren't involved in the procurement of the hospital and the specification of it, mainly because you weren't there. You arrived in 2012. So firstly, it'd be interesting to know what you were told about this new hospital when you arrived as medical director in 2012. What was the way it was pitched to you as a facility and its level of standard?
Uh, So maybe if I could go back a little bit. So I was, before I left Glasgow, because I came to work in Edinburgh for 7 years, I was involved in the acute services review. And what that was doing was that there was 5 very old hospitals in Glasgow, and I was leading the side from the north of the city. So what I knew about it was that we were bringing together 3 huge teaching hospitals in Glasgow, as well as then later on, about 2004-05, we then added in the Royal Hospital for Children at that point. So from my point of view, when I arrived in 2012, I knew it was the consolidation of 3 big teaching hospitals. It was also the York Hill was moving over, as well as a number of other hospitals, about 4 or 5 hospitals. So for me, it was the end of an acute services review that had seen the brand new Beatson open, I think 2009. It had seen the ambulatory care hospitals open, both in the Victoria Infirmary and in Stop Hill. And this was the end of a strategy which started in 2002. And for me...
Sorry, carry on.
Sorry. So for me, it was a tremendous thing. But for the new hospital, I was expecting a fantastic hospital. I really did, because I thought it was a great step forward for Glasgow and Clyde. I was really pleased. It was called the triple co-location, to bring the Children's Hospital on board and maternity. So it was the first time we'd brought district general hospital services, tertiary services and children's services. So I just thought it was great. And when I arrived in 2012, the new labs block opened. And you've heard a bit of evidence around that when the labs were consolidated on that. So that was the very first thing.
Yes, because the thing that I wanted just to sort of capture from you is that we're going in a moment to talk about what's in your statement about the realisation that particularly the adult bone marrow treatment unit, in various ways, the ventilation wasn't what people hoped for. And we'll talk about that in a moment. But I just want to understand what you, as it were, thought before you became aware of these, I'll call them problems at the moment. So you were involved in the original decision to move the adult bone marrow treatment, to add that to the project in 2013.
Yes. And do you want me to?
Yeah, do. Please say this.
So in May of 2013, I remember it pretty clearly, the clinicians had come to me to say that they wanted to be co-located on the new big hospital. It was called the New South in those days, because we needed to co-locate them with intensive care. And also, as you know, the bone marrow transplant are the sickest patients by a long shot. And therefore, we wanted them to be next to the renal physicians, next to respiratory, the whole bit. So what I asked them to do at that point, because they were initially they wanted to move more beds over, and at that point the hospital was being constructed. And so I asked them to speak directly to the project director, because I wanted to make sure that we got the right specification. And what happened there was we probably didn't have enough beds, so we couldn't take the elective hemato-oncology over, but it was the bone marrow transplant. So I took it in July. I think it was called the Q&P committee, and we had to, I think it was about 800,000. Now, my understanding at that point was the hospital was in the process of being built. So I didn't understand that it was going to be a compromise, if you know what I mean. I thought it was going not to be a compromise. So the clinicians were keen. I took it to the Q&P committee and asked for about £850,000 along with the chief operating officer. And at that point, they agreed, because I put forward the clinical case for it. And then we handed it over to the project team and the design team, and I didn't see it
Indeed,
again.
it's a useful example, because it enables me to prompt a supplementary question, is that we've had some evidence, I think, that the ventilation systems that are ultimately installed in the hospital do not have enough duct capacity to deliver, without major refit work, more than 6 air changes an hour, even with a lot of work. And so we'll get to how this story happens in a moment, but ultimately Ward 4B gets to 6 air changes an hour and it can't go any higher. Is that, you share my understanding of that?
I didn't at the time.
Well, I appreciate that.
But as I've gone through time, but I could maybe, when we get to talk about that, I could maybe tell you exactly how that
well, indeed,
came
but
about.
just picking on the idea that we sort of now know
Yes.
that it can do 6, but it can't do 10.
Yes.
And it's been put to a couple of witnesses that maybe if people had known back in 2013 that you couldn't do 6, it might have prompted a different decision. Maybe either people would have spent more money on bringing it up to standard, or they might have decided not to bring the bone marrow treatment patients over, just notwithstanding all the good reasons you've just given. And so do you see there's a sort of what if counterfactual there? If people had realized in 2013 that the ventilation system in the building that was ultimately built couldn't actually support the standard of 10 air changes an hour, that might have either made the decision harder to bring the BMT over, or in cause not it to come over at all. Do you see that's a sort of a realistic hindsight question to ask?
Yes.
Right. Because what I want to do is to look at a particular
Could
document.
I answer it though?
Yes, of course.
Yes. So what I would say to you is that we were actually facing that position. When you're looking at the safety of a service, the environment's part of it, but it's only part of it. And what the bone marrow transplant clinicians would say is another big part of it is actually having the co-location of intensive care and the co-location of renal and the co-location of respiratory. And certainly, I actually went round the unit, and I can talk more about when we come to that and tell you exactly how we managed the difficult circumstances we came to. I talked to them, and actually one of the consultants there, I knew in 2013, way back then, and he said he would always still come over.
Well, I do appreciate that those balancing axes are happen, and of course one does happen in respect to the paediatric BMT after it's moved in. There is a balancing exercise that's carried out, and it's decided, if I got this right, that they have to do the bone marrow transplants because they need to do them. Even the rooms aren't quite what people want. Is that roughly a quick summary of that position?
I'd probably, so you'll have seen in my statement, and I don't want to go forward if you don't want me to, but you'll have seen the complex decision making that we made around that in September
Indeed.
2015. And so it's not quite as easy as just saying you need to transplant or not. There's a whole series of factors that were taken into account there in terms of the pressing need to do it, in terms of what infection control are telling you, in terms of what states are telling you, in terms of what the clinicians are telling you. That's what I'm saying, that patient safety is a balance of many risk factors. And it's quite a complex, carefully thought through process. But in the end of the day, the only thing that matters is making sure the patient is safe. That's it. And you have to make those decisions, and you can't walk away from them, particularly when there's a child at risk.
Right. So, well, I think possibly that's two very helpful answers because you've saved me having to go down those routes. But I'd like to look at a particular document. Which is in bundle 14. It's document volume 1. It's document 3, and it's at page 82. And it's an update paper timeline, which is actually produced, we understand, on 26th of April for you. I think possibly by Mr. Vine.
No, it actually was Dr. Inkster that sent it to me.
Oh, very helpful. So it consists of extracts from a series of, or sort of, would you say it as sort of a summary extract of a series of emails?
Yes, I do, and I was intrigued as why that actually asked for it. But yes, it is. It's a series of emails, and it's up to April 2016.
Because what I want to do is just to look at things that happened at two discrete points. And one of them is before handover, and one of them is in the discussions that occur primarily around the bone marrow treatment units after handover. I want to ask you a series of questions about what you did and what you could have done at the time. Now, if we look at this summary, and I appreciate it's not your summary on this page 82 of 11th of August 2014. So that's what, 5 months before handover.
Yes.
And this email isn't to you, to be fair. It's an email to Miss McNamee, and there's some discussion about infectious diseases, and at very short terms, there being some difficulties with the way things have happened. And I'm keeping it at that level because I don't want to get into the detail of what it said. It's more what it tells you. If we go on to the next page, we have a BICC minute. And again, this is discussion from Dr. Seaton. I appreciate that Dr. Seaton ultimately takes a particular position and gives you some advice about this unit, But the issue of the infectious diseases comes up at a BICC on the 6th of October. Do you remember this BICC?
Vaguely, yes.
Yeah. And then December, you've described this in your statement. There's another BICC, and Professor Williams is now giving some information again about the isolation rooms in the infectious diseases.
Yes.
And then if we go on to the third page, there's another BICC in January, the day before handover. And you see about 6 lines down, someone's recorded, Dr. Armstrong stressed that the keys to the new hospital were being handed over tomorrow. Now, in a sense, there's a similar email trail around the adult bone marrow treatment isolation rooms a little bit later in time, in which people notice that they're not as people hope them to be. There are holes, there is filters missing. And the same sort of thing happens with the pediatric bone marrow treatment rooms. Again, people notice that there aren't HEPA filters. And again, it's a little bit slipped forward in time. It's in 2015 in both cases. But would you agree there's a similar realization that there are some problems and then discussions of what to do about them for all 3 wards?
I don't think I would agree with that. The reason being that I remember this series of events. So in 2014-15, and just to put it in context, there is a project team, there is estates teams, and there's a project director, so David Loudon, and there is the building taking place. But we were not involved in that, and I certainly wasn't involved in that. And there's contractors and everybody else. And I had not been aware the infectious diseases unit was a late addition.
Yeah, I think Brookfield weren't aware at one level.
So I didn't know about that, but it was a late addition. And what was happening here was different from what I think you've described. What was happening here is that the lead infection control doctor was saying that he didn't have the assurances that he was seeking. I think now I'm not an expert in that, and I'm taking advice from them, but it seemed to be around the guidance. It seemed to be around whether or not the guidance was fit for the rooms, both in terms of the bone marrow transplant and in terms of the ID unit. And so they had to then write to David Loudon. I asked them to write to it because I wanted it documented.
No, you did ask them to write to David Loudon,
I
yes.
wanted to write to David Loudon, also because I was not the expert in this. So there was no way I was trying to put forward to him what it was. And I wanted clear advice. I was surprised it was this late in the day, I have to say, but I wanted clear advice, and I also included the board chief executive because it was the project team doing this. So what happened was they wrote, as you can see, in December, January, and it comes back, and I didn't even know who the contractors were. I expected the project team to be able to give the advice. And then there was a series of emails between Craig Williams and indeed the project team.
We have them in our bundles.
Yeah. So the reason I'm suggesting it was slightly different was what came back from that, from my recollection, and this is advice that has been given by the project team, by the contractors, and by the lead infection control doctor, was that there was guidance, but it hadn't been updated, but they felt that what was on the table was fit for purpose.
Absolutely.
And therefore, that was then accepted by it was up to the project team to do that.
So in terms of the infectious diseases, you're explaining that questions arose, advice was sought, and the response you get back is they are indeed fit for purpose.
Yes.
Right. For the adult, and I don't know whether we need to take you to the documents, I'll just put it to you, see what you think. For the adult bone marrow treatment isolation rooms and the pediatric bone marrow treatment isolation rooms, have I got it right in that in those 2 cases, what happens is there are questions about the physical fit out, whether the building, those 2 sets of isolation rooms are physically fitted out to the standard people were expecting. Have I got that right?
So in this particular, so if I can just take it chronologically, and I'll come to that. So in this particular issue in 2015, because I was very clear, this was pediatric. Adults was not mentioned. And this was about whether or not, now again, I was not at all au fait with all of the technology, but this was about whether or not the rooms which had been built were fit for purpose. And it came back that yes, they were. So this was before we took entry. After we took entry, the first thing that I knew was around the 1st of July, which was the adult bone marrow transplant. And that was a series of emails which I thought we were getting, as I've said before, a fantastic hospital because we'd been working so long for this. But we didn't get what we expected. And the first thing that was, in terms of the fit out, was the 1st of July for me.
Yes,
And that was the adult
but
one.
the point I'm trying to get across, and maybe I'm taking this at far too high a level, is that during the period just before, but mainly just after handover, there becomes a realization that in respect to the isolation rooms, there are some things that are not right. Would you accept that?
From my own point of view, I didn't know about the after handover. My involvement was this particular involvement for the
So
infectious diseases.
let's put infectious diseases out the way. Let's focus on the 2 bone marrow treatment units. Have I understood it correctly that in 2015, there comes a point during the year for both adult and pediatric BMTs when you become aware that there are aspects of the physical fit-outs of the isolation rooms in those 2 wards that are not what other people are expecting?
So I take it chronologically, in the 5th of June, prior to the paediatric bone marrow transplant, I became aware that the HEPA filters had not been fitted.
Yes.
In the 1st of July, after the adult bone marrow transplant unit had moved over, I become aware absolutely that that had not been built the way it should have been.
Right. So we have that.
Yeah.
Now, you are very clear that you're reliant on the advice of the project team and the infection control doctor. Have I got that right?
Along with the clinical team as well.
Along with the
yes,
clinical
yeah,
teams, yes. And in respect of the pediatric bone marrow treatment rooms, if we look at Bundle 14, Volume 1, page 200, we have an email to you from Professor Williams explaining that they found some problems and that he's spoken to Marianne Kane about the issue. Remember that?
Yes.
Yeah. Then we had, and we then have a situation where there's a series of more emails. So we then have an email on the 7th of July. Let me just check I've got the right page reference. Sorry, wrong bundle. So that's the pediatric one. We then have an email from Professor Williams to you on the 7th of July about the adult pediatric unit, and that's Bundle 27, Volume 9, page 411. And the next page, I think, is the document itself. Do you remember seeing this document from about the specification of what's being built in adult BMT?
I remember it looking back, yep.
Yeah. In fact, the adult BMT have gone back to the Beatson by this point.
I think it went back on the Monday, so possibly. Yeah.
Yes. So presumably that was quite a big thing for them to do.
Absolutely. I think, yes.
Yeah. And then we have Professor Gibson. Well, that's
Can
before.
I just say something about this?
Yeah.
Please. So I think what I said in my statement was, I don't think I would have asked for this because at that point, my focus was making sure that the patients got safely back to the Beatson. And this, I think, was then I passed this on to the Chief Executive of the Health Board.
I want to come to that. I'll come to that in a moment. Let's look at another document, this time Bundle 27, Volume 8, page 213, which is an email of the 10th of August, a meeting of the 10th of August. Now, Grant Archibald's in the chair, and you're present, and this is about an action plan for the adult bone marrow treatment. So there's meetings happening, and that's all I'm setting up a question, Dr. Armstrong. And then we have Professor Gibson emails you on the 4th of September about the Shahali unit, which is Bundle 8, Document 31, page 133. And you see what Professor Gibson is saying in that email. It's quite a strong email from Professor Gibson.
Yeah, so if I just go back to Grant Archibald's
Yeah.
thing. So what happens is, so Grant Archibald was the Chief Operating Officer for the acute division. So the responsibility, as I said
Yeah, but
before...
Dr. Armstrong, the reason I'm not asking you about
Yeah.
Grant Archibald is I want to ask what you did. So
Oh,
let
yes,
me get to
so-
the question, and then I'll ask you the question. So we have an email here from Professor Gibson, and you'd appreciate, although there is a follow-up meeting and the issue is resolved and bone marrow transplants take place, at this point, she's quite firm that there's an issue. You'd accept that?
Yes, what I would say, at the beginning of August, I got an email from Sandra Devine because a child had been cancelled because there was a problem in the paediatric bone marrow transplant unit. At that point, I forwarded that email to Grant Archibald and indeed phoned him, and to Robert Calderwood, and that led to that meeting that you've just put up there.
Yeah, absolutely.
And therefore, what they had been doing since that time, and I can't remember, I think it's the 10th of August, they had been working with the team to try and address the problems of the paediatric bone marrow transplant unit. But I absolutely understood that Brenda Gibson then came to me on the 4th of September to say that it had not been resolved.
And eventually they source HEPA filters from Northern Ireland, and the transplants go ahead.
No, sorry. The Northern Ireland thing was prior to that. So before the paediatric bone marrow transplant unit moved over, that was on the 1st of June and 29th of May. And Mary Ann Kane was walking around the unit and found that these HEPA filters had not been fitted. At that point, we were maybe faced with stopping the Children's Hospital opening. So there was a series of meetings taking place. The HEPA filters were sourced from Northern Ireland and they were fitted. And then the paediatric unit opened after that. This was later on.
So the reason I've shown you all those documents and rather cut you off is that as I appreciate, and I don't think anyone's disagreeing, that there is activity.
Yes.
Attempting to address the problems.
Yes.
And one can have a dispute, we maybe might get into that in a moment, about whether the activity was adequate, but there's no dispute that there was action being taken by you, Grant Archibald, the project team, and the infection control team. You'd agree with that?
Yes.
Yes, right. I'm asking a different question, which is this. At this point, we are now some months after handover in a hospital where questions about whether the building is built as people expected it to be built and whether it is built in conformity to guidance have come up on a number of occasions. Would you accept that?
Yes.
Right. I absolutely understand that you do not have the expertise yourself to assess whether the building is built in conformity to SHTMO 301. You'd accept that?
I didn't know what SHTMO 301 was at that point, but yes, my focus was on the patients.
Yes, but one of the problems with a building is it's a very complicated system. And what I'm putting to you is this. If the building is so complicated, and if you've become aware, and it's you personally, and I appreciate we've asked the same question of lots of other people, and we will ask the correct question, no doubt, the chief executives in due course. If you become aware as the medical director with the responsibility for patient safety that in respect of these two wards, there are things that are not built to specification, and in respect of the isolation, the infectious diseases units, there is some doubt about whether what guidance to apply, should you not become suspicious of whether the project team and or the contractor had done their jobs properly and started asking questions about that?
What I was expecting, as I said before, was a hospital that would be handed over fit for patients. And therefore, when it became apparent that the adult bone marrow transplant unit had to move back, that was extremely surprising. And we had to, my focus was making sure that they moved back safely to the Beatson and we transferred that. When the paediatric, and again, as I say, Grant Archibald was the Chief Operating Officer, there is a women and children's team beneath Grant Archibald, and they, along with, and I think I've said in my statement, along with the infection control team, with the estates team, are responsible for providing those facilities. But yes, we were all, I think, taken aback with the fact that it had not been built right. And that needs to be taken forward, I think, by the project teams and the builders, but that was not my focus.
No, you see, the question I'm suggesting is that that's the wrong approach. Because if someone has made a mistake, and it's, I suppose, a purpose of this inquiry ultimately to find out if that's true. If someone has made a mistake about not building it correctly or not specifying it correctly, the answer may well be found in the conduct of the contractors or the project team. So what I'm suggesting is that you, as HIA executive lead and medical director, had an obligation to ask this question: if these things are wrong, what else is wrong? And I don't think you did that. I'm putting that to you.
I would have certainly reported all of this to the board chief executive, and the project director, who actually was responsible for delivering the building, along with that team, along with the people that were delivering it, were absolutely responsible for looking at that. I was raising the issue and trying to fix the issue so that we could get patients treated.
Did you raise the issue of, if these things are wrong, what else is wrong?
I think that at that point, there was the bone marrow transplant, the adult, there was the paediatric one. The isolation rooms were further on into 2016 for me. And at that point, I did actually send an email to the chief executive, I think around...
But in 2016, but I'm looking at 15. So, but
I would, yeah.
So I'm trying to get from you, Dr. Armstrong, really quite simple, because it may actually just the answer, maybe just no, is, are you saying that at the point of 2015, you focused on fixing the problems rather than working out how the problems had occurred, or at least encouraging someone else to work out how the problems?
I was encouraging someone else to do that. I would not. The project director was also the director of estates. When the adult bone marrow transplant went back, we were expecting that they would look at what went wrong and what happened prior to that. I don't think that would be within my remit to do.
But it would it not be a problem? We haven't spoken to Mr. Loudon. We will have to do that and hear his side of these events. But it's not impossible to imagine that the thing that went wrong happened, as it were, on his watch within his team. Now, that may not be the case, and we'll hear from him in due course. But what I'm asking for you is, you're the senior clinician in the health board. You're the hospital HAI executive lead. And I get the impression from what you're saying that whilst you were focused on fixing the problems, you weren't saying, I'm now worried about what else is wrong.
I was worried about the adult and the paediatric bone marrow transplant unit. The rest of the hospital, and there was a lot of other things going on at that time, because when you're bringing in 5 big teaching hospitals, the rest of the hospital was things like emergency department flows. It was things like the acute medical receiving. So there was a big other part of that hospital which was working well, although we had problems with flows and problems with winter and various other things. So where I could see it was, there was problems with the paediatric unit, which was significant. There was problems with the adult bone marrow transplant unit, which was significant. But we had a whole range of other specialties which were working. We had theatres going on, we had trauma going on, we had acute medical receiving going on. So what I'm trying to say to you is, we were absolutely raising that with the project director to see what happened here.
Well, what was the answer you got?
I think the answer was that they were speaking to the contractors, and because it wasn't in my remit to get involved in those conversations. So that was being taken away from where I was. My focus was very much on patients, paediatric patients, but also all of the other parts of the hospital as well.
Because one of the problems with that is that we heard from Professor Steele last week, and one of the things that Professor Steele was very, very clear about was that on appointment, he had a meeting with the chairman and the chief executive in 2019, albeit 4 years after these events. And he decided with them to conduct a review of the procurement. And he did that review of the building, and he covered in the review, I think, everything apart from chill beams that we've talked about as a possible flaw in the building. And he obtained a report from a contractor, from a consultant, and indeed it may be, I think he's admitted it, then to some extent resulted in your litigation against the contractor. So he acted to find out what had gone wrong. Now, his predecessor in 2015 was also the project lead. So there was no one in the States outside the project team who could ask that question. But you were the medical director. And so you could have said, I want to know what else is wrong, because we do know now that there was problems with the water system and there was problems with the general ventilation, but you didn't find those out. And it may be, and I'm putting that to you, that you didn't ask, and maybe you should have done.
I don't think it is within the remit of the medical director to look at the areas that you're talking about. When we had problems with the bone marrow transplant units, and indeed any other problems that arose, then I was very, very keen on sorting it out, as well as keen on the patient safety aspect. But it is not within the remit of, I believe, any medical director to actually then go into the estate side and be able to ask questions around what was the water system like. That is actually the responsibility of the project director, the director of estates, and the general management system.
Would it be within the knowledge of the medical director that there is a SHFN 30 HI scribe document that at Part B sets out what processes you have to carry out to certify new or refurbished facilities? Is that something you would have known about then?
No, absolutely not. That was not. I saw it in the papers, but no, I was not aware of that.
But the very title is HI scribe, Hospital Acquired Infections Scribe, and you're the HI executive lead. So why can't we assume that you would know about the processes to prevent hospital acquired infections?
I would not know about those. There is a team that works, the senior management team in infection control, and there's a lot of experts within that. And I did not have detailed knowledge about HAI scribes, certainly not in terms of a new hospital. So I think that those are not assumptions that I would make. It was not knowledge that I had at the time. And I don't think that many medical directors would have that knowledge. What you're relying on is groups of experts, of individuals, to make you aware of that if that's required. But for the new hospital, for the Queen Elizabeth Hospital, that was being handed over to us, we believed, with, I didn't even know that you had to do these types of things. So that was not within my remit. It was not within my knowledge base at the time.
Just clarify that last point. You use the expression, you are not aware of the details of H-scribe. Do you mean the details, or perhaps you may not have been aware of the existence of such a process? It's just for me to understand what you are not aware of.
In terms of so I had been the HI exec lead for 3 years at that point, and I knew that there was processes in place when we were doing refurbs, but that was part of the team. It would come up maybe in the Board Infection Control Committee. So I knew that there was processes that needed to be put in place, but I wasn't aware of the detail, and nor should I be, because there are experts that do that. But when people are, pulling things out of old wards, that kind of thing, then there needs to be protection put in place. But that's not something that somebody at my level would be aware of the detail, and certainly not in terms of what's been described here about new hospitals being handed over.
I understand, maybe not aware of the detail. You were aware that there was a process in relation to refurbishment. Were you aware that the same process applied to new construction?
No.
Thank you.
What I want to do is now move on to what I've called, and I posit it's my shorthand, the working relationships within the infection prevention control team as they emerged in 2015. And we had evidence from Dr. Stewart. Now, am I right in thinking that Dr. Stewart was your deputy at the time of the new hospital moving in, and most of his work was around acute services?
Yes.
But occasionally, and I think it was my word, he accepted occasionally he'd be a bit of a gopher for you and go and do things that needed to be done on your behalf. Is that that aren't directly related to acute services?
He was the chair of the Acute Infection Control Committee, I think, during that period, and he would work with me on certain issues, but that wouldn't take away his responsibility for the acute sector.
Yeah. And so the events that happen, and again, so we don't use up time going into documents that are very long and have lots of detail that isn't important at this point, is that we've heard evidence that on the 7th of July 2015, there is a meeting between Dr. Cruikshank and Dr. Peters and Dr. Inkster, possibly Professor Jones, in which they intimate their desire to demit or renounce or resign their ICD sessions as sector and regional ICDs. Now, I suspect you didn't know about that at the time, but you now know about it. I'm just checking.
I knew about it probably around the 9th of July.
Yes, because Dr. Stewart would have, or Dr. Cruikshank would have come and speak to you.
Well, the reason I can't remember exactly who spoke to me, but I have got an email between myself and the chief executive when I'm making him aware that I've become aware that there are 3 ICDs who wish to demit their sessions for that.
And 2 of them provide letters to Professor Jones. And ultimately, am I right in thinking that you asked Dr. Stewart to carry out some sort of review of communication and culture and the way the IPC team works?
So what I do recall from that time was, because it was such a busy time getting the hospital ready, as well as all the other infection control issues, was that I got, I think, a phone call from Tom Walsh, I think, to say that this had happened. And what we had to do was stabilise the service. And I think I spoke to Brian Jones and said that and he was very reasonable, that we couldn't allow it. Just, if I can take a step back, all the consultants have got job plans. And if you want to change your job plan, supposing you're a surgeon and you don't want to do a theatre session anymore, that's got to be done.
You've got to go through the job planning process.
You've got to have, well, more than that, you've got to actually have the local management team's view on it, because it might be that you're the only surgeon that can do that type of operation, and we've got a big waiting list.
Well, indeed, and these 2 doctors weren't permitted to demit their sessions.
Well, I think what happened was that Professor Jones said he would keep them in their sessions because we didn't have anyone to backfill them. I then have, and I've looked at the email on it, I then appraised the board chief executive of that. I say I don't know the reason, because I didn't know the reason at all. And what I do is I ask David Stewart to investigate the reasons why they had demitted their sessions, and that's what I was looking for.
Ultimately, does he produce a report?
He produced a report, I think, that I saw maybe in October 2015.
Yes, so his report is... I'll come back to his report in a moment, but he produces a report, and that report is provided... Who do you get it? You get it from him in October?
It was I think it was October. I think what happened was he had shown me the report. I had not seen I only saw them in the bundles, actually. I had not seen the reasons for the 2 infection control doctors wishing to demit their sessions. But I saw something, I think the 30th of October, and it was being sent to Anne Cruikshank, and that was the report. He must have shown it to me slightly beforehand, but I saw it roughly around about that time.
Yes, and so what I'm wondering is, he produces his report, and the way it's described by the people involved, to him, Dr. Inkster, Dr. Peters, Dr. Cruikshank, is that he sends an email out to the infection prevention control team saying, I've done some investigations, and in very short compass, we're going to do various things. We're going to have a development day. And Dr. Peters and Dr. Inkster reply back to him saying, what are you doing about the patient safety issues? And his evidence to the inquiry was that he'd told you about the patient safety issues that they had raised with him. Do you remember that?
No. So what I got was the report, which seemed to all be about the dignity at work issues, as I would put that.
Yes.
I hadn't seen the letters until quite recently, actually, of why they wished to demit their sessions. What I did see in November of that year, I thought it was 2 separate processes, to be honest. I thought they had a process which had been about demitting their sessions because of dignity at work issues, and then there was separate issues raised in November of that year. Because what happens is, and I remember the email goes out the 30th of October, and then I think Anne Cruikshank comes back with a long email trail around that about what about the patient safety sessions, what about these things. I then get involved in trying to get Anne Cruikshank into the clinical director role, because I thought if we had a stable, safe pair of hands in that. And then the first time I become aware of the patient safety issues was on the second lot of emails, which were sent out, I think, round about the 9th of November, I think.
Well, I'm going to come to those, but before we get there, what I wanted just to do was put 2 things to you. One, it was Dr. Stewart's evidence that he told you about the patient safety issues that were raised in July by Dr. Inkster and Dr. Peters, but that you only asked him to carry out the Dignity at Work review?
No, that's not my recollection, and it's not in the email trail that I have sent
Well, I
to
think he
Robert
explains he
Calderwood.
spoke to you, but yes, okay. What I want to do is to then look at the review itself, which is Bundle 14, Volume 1, Document 41, page 464. So I want to ask you about part of it, because it will become important later, which is if you look at paragraph 6, and I realize it's quite a long report, but I have two questions about paragraph 6. So do you remember reading this report?
Yes.
Right. There is a statement, presumably by Dr. Stewart. There is also the need for greater clarity around levels of accountability in the decision-making process, especially where there are conflicting views, opinions. Now, at the time, would you have agreed with him about that sentence?
I certainly agreed around the conflicting views and opinions, and the decision-making process.
Would you agree there needs to be greater clarity?
Yes.
Yes. Now, the next sentence, I'm not necessarily asking you to agree or disagree with the next sentence because you didn't carry out the review. But I wanted to see if I'm right to read something into it. And I read the next sentence, the one that begins, on the one hand, two statements of things that were raised with him. One is that, on the one hand, there are reports from ICDs of having their professional authority undermined by the overturning of decisions by the IC management team. Now, he's explained he doesn't remember the report, but Dr. Peters and Dr. Inkster insist they raised that issue with him, and here it is in this paragraph. And I wonder if you would have assumed from reading this report that one of the issues being raised with him was that ICDs felt their professional authority was being undermined by overturning decisions of the management team. Is that something you would have drawn as a conclusion, that someone's saying it, even if you don't necessarily agree?
He was interviewing a number of people as part of this report, and he was doing that with Bridget Howitt, who was the HR person associated with this. And so therefore, when he's writing this as part of his findings, then I'm taking that was part of his findings, because he's talking to both the ICDs and he's talking to the management team as well.
Indeed. And so he's saying there are reports of this thing in the first half of that sentence. And then the second half of that sentence, he's reporting something else that has been said to him. Whilst on the other, I think hand is missing, there are reports of ICDs not taking decisions when given authority to do so. And I presume he's heard that from some people. And so what I'm just checking is that sentence seems to imply that at the time this report was produced, two issues were known, not only to him, but to you, which is that there was a view amongst ICDs that their authority was being undermined by their management team, and equally, possibly from the management team, a view that ICDs were not taking decisions when given authority to do so. Am I right to infer that from that paragraph?
I think that one of the things that he had suggested, and when we do these types of reports, he had suggested bringing the different parties together, I think, for a meeting.
He did suggest that.
Yeah. And sometimes that's actually, and I've had to do that a few times with teams who are, who may have different perceptions, or there's conflict within the teams. And often it's better to bring them together to actually get, exactly what does that actually mean.
No, I appreciate that, but what I'm
examples
checking is
of that.
your understanding. Because you asked for this review to be carried out and you received the report. And I want to just check that at this point, in October 2015, you would have known, amongst all your other responsibilities in a very busy time, that there were ICDs who felt their professional authority was being undermined by ICPC management, and also that IPC management felt that ICDs were not making decisions they should be taking. And I want to just check that would have been something you would have known from reading this report.
From what Dr. Stewart's written in the report, that's what he's written. I would have probably wanted a bit more to explore that a bit more.
Of course,
to,
yes.
to try and understand what that actually means.
I wonder if you can help us, because he doesn't remember what the final sentence means. So this is, whilst it's clear there are concerns for patient safety as the primary motivator for ICDs and arriving at decisions, there appears on occasion to be a lack of appreciation by some ICDs of the need to risk assess decisions from an organisational perspective. Now, the way he reacted to that was that I suspect is a meaning that doesn't require the word political to be in there. It's a sort of risk balancing exercise of the sort you and I have already discussed this morning. And I wonder what you take from that sentence.
I definitely don't take it's about politics.
Because
if that's the inference you're making.
no, I'm not. I want to know what you take from it. What do you take from it?
I think that with infection control, and I think that Dr. Stewart probably touched on this, and it is very true, is that with infection control, it is one part of a decision-making process. So things like closing wards, all the things that we have to deal with day in, day out, or over winter, you're always trying to make a risk balance of how you actually do it. So what is the risk of the infection? I mean, a good example of that would be winter. So if you look at winter, we've got ambulances that are often queuing outside a hospital with sick patients in the back of them when we need to get them into the hospital. And therefore, there's got to be a risk-based assessment made by infection control teams, the clinical teams, based on actually what the circumstances are. And those decisions may vary depending on, if you're in the middle of winter, but they will always be based on patient safety. So you're always trying to maximise that. And I think that's what he meant by that, because that happens in hospitals right up and down Scotland about how that's happened. And it needs to be done as a joint endeavour between infection control, between clinical teams and managerial teams to make sure that you're maximising the patient safety.
So the final question is indeed about the word political. One of possible perspectives on that is that to be fair, he didn't accept this, but is that sentence is thinking about the reputation of a board.
I did not read that into it at all. This is a report about how we manage infection control. It's not a report about anything to do with the board.
What I'd like to do is to look at the letter of the 9th of November, which you just mentioned, which is Bundle 14, Volume 1, Document 48, page 478, which is 9th of November 2015. Yes. So I take it you saw this letter at the time.
Dr. Stewart would have discussed it with me at the time and forwarded it to me at the time.
Yes, because his evidence was that this letter is prompted, the emails show this letter is prompted by him providing a reply to his earlier email that he understands the matters had been resolved, had been addressed. And he tells us that his source for that information is you. So how would he have known how the matters in Ward 2A and 4B had been resolved?
Well, if we can get the timeline correct, so Dr. Stewart is the acute medical director, and that means that you also are looking at patient safety, you're looking at all of these issues, and in fact, I think he was also involved in the Ward 4B discussions at that point. So the acute medical director works with the chief operating officer, works with the nurse director and a team, and they will then work with all of these different teams to do that. But I think with this particular issue, this was the 9th of November. And there is, when he, I think, sent this to me, I sent back an email to him, and I've got that, which says, can you work with colleagues, because this is not just about infection control, this is about a lot of other issues. Can you work with colleagues to address these issues? He then, as you say, then sends a letter back to the ICDs, I think round about the 20th, so after
just before
this,
Christmas,
in December, yeah, 20th of December, and then comes back a response from, I think it was Dr. Peters, to say these issues are
in fact, they seem to think it's got worse. Is that their evidence? Than what
yeah, so what she does is she lists those, and he then speaks to me about it, and then I escalate them, and particularly around the children's one and the bone marrow transplant one, we then have a meeting at the end of January.
Yes, because the point I want to see if I can get you to acknowledge is this, is that there's a work stream that you're heavily involved in, Grant Archibald's involved in, reacting to the problems with 2A and 4B that we've discussed already. And then along in November comes this long email from Dr. Peters and Dr. Inkster, which seems to be raising additional issues. And you then decide to act on it to some degree. You pass it on to somebody to action it, as you just said. Am I right in thinking that at this point, in this email, and maybe the one that follows just after Christmas, the authors, they're not wrong about the state of the isolation rooms in 2A, 4B, or indeed elsewhere in the hospital, are they?
So there is a lot of debate. So just taking it bit by bit, there are 3 or 4 different teams involved in the Queen Elizabeth at that point. And as I said before, and I think it's quite important for the
No, I do understand that. The reason I asked was I do understand lots of teams. I'm asking for your opinion as to whether at the end of 2015, in this email and the one that you've just discussed at Christmas, which you then pass on to other people to action, at this point, are Dr. Peters and Dr. Inkster actually wrong about anything they're saying about 2A, 4B, or the isolation rooms? So
in terms of the 4B one, there is work going on that, and Dr. Inkster is involved in that, and absolutely there is there is work. So 4B is back over at the Beatson at that point. And if I can just tell you a bit about what happened at that time around 4B. So 4B is now back at the Beatson, and the debate was around what facilities do we need to put in place to bring the patients back. And around about that Christmas time, what we were beginning to do was pull in the regional director, and we were getting a team together with HPS, with the infection control team, which involved Dr. Inkster, with the regional team who managed this process, and with the clinicians. And the idea is we get all of these people together so we do a proper risk assessment.
I do understand that, Dr. Armstrong.
So there was absolutely a recognition that in order to bring those patients back, there had to be a lot of work. And if I can get the opportunity, I'd like to tell you exactly how that did work.
Well, so I mean, I think it's important to realise before we go on any further that we can read your statement. You've got a very long statement you produced. We've had lots of evidence, and I absolutely accept there is a process. We've heard evidence about it. Steps are taken to address 4B. There's an SBAR from HPS, albeit it doesn't. There's another SBAR a few years later, and they eventually moved back in 2018. We'll come to that. But all I was asking the question about was this: is at this point, in November, December 2015, am I right in understanding that, in very broad terms, what Dr. Peters and Dr. Inksters, who are the sector ICDs, at that moment are saying is right? So yes, no question.
So what I'm saying to you is 4B, everybody was aware of that. So,
I know that, but I'm asking whether they're right.
I think I suppose what I'm trying to say to you is, yeah, they were bringing up good points, and right. I wouldn't say that's absolutely fine. That's true. But there were management teams, clinical teams, infection control teams, and estates teams who are trying to address that. And therefore, there were a number of teams who are working towards that. And if we get the opportunity, we can talk about 2016 in 4B as well, because there's work.
Because the point that they make, and I need you to respond to it, is that they were the sector, at that point, despite their best efforts to resign the sessions, they were the sector ICDs for South Sector, which means Dr. Peters had a responsibility for 2A, and regional sector, which means Dr. Inkster had a responsibility for 4B. And they were being asked to take responsibility for these 2 wards in infection prevention control terms. And their point was they weren't being told stuff. Largely, they would say, I think, by Mr. Walsh and Professor Williams. So they raised this issue with you. And as you say, these are good points. And there is then a process that follows. But I'm just trying to understand that they're not wrong to raise the issues, are they?
Oh, no, absolutely. Right. They're not wrong, but can I pick you up in a little bit there? So 2A at that point was actually Professor Williams. He was doing paediatrics at that point. And Dr. Inkster, I think, came back into the 4B debate around about roughly October 2015. And what had happened was there had been work done with the contractor, with Professor Williams and with the regional team. And Dr. Inkster then took that over. She expressed concerns with that, and she was absolutely right to do so and within her remit to do so. What I was focused on was then, I think Dr. Ince had asked for HPS support, and then I formalised it, because you have to have a formalised...
You do, and we end up with an SBAR.
Well, we end up with an SBAR, but what we also end up with is a multidisciplinary group, because you have to have not just infection control, but we have the clinicians who are the hemato-oncology clinicians, we have the estates, we have the infection control, and we also have it led by the regional director, Gary Jenkins. And there's an email, I think it's in January, where we set that out. And in fact, we discussed that, because you need a risk-based approach. And Gary Jenkins was reporting direct to Grant Archibald, because that is the way the governance structure works.
Now, the next thing I want to ask about is in 2016, Dr. Inkster is appointed as lead ICD after Professor Williams moves away. And I wondered what your assessment was of the impact on the IPC team, and therefore the whole hospital-acquired infection responsibility that you have, of the arrival of Dr. Inkster as lead ICD. How would you assess the arrival of her at that point in 2016?
I think in April 2016, it was a competitive interview for the job, and I didn't take part in that.
No, I'm not saying you did.
And she was appointed lead ICD, I think it was April 2016. And she worked with Tom Walsh and with Sandra, and I think it worked reasonably well. And Cruikshank at that point, I remember emailing me to say, should I step back? I was keen for her to remain a bit longer, because I wanted it to bed in. And in fact, I don't think she demitted till about August. So
her evidence is it wasn't actually extended. She just did the 6 months.
No, she emailed me to ask me what did I think, because I thought she brought stability to the team. She brought a maturity to it, and I was quite keen. At that point, we'd also had one of the senior team had gone off sick and was coming back from sick leave. So I was quite keen that we got a bit of stability. And then when Teresa came in, I think it was good, because we had an LICD, we had a nurse, and we had an infection control manager. And there is a series of emails again where Anne Cruikshank's coming back to me saying, will I go? And I'm saying, well, just give it a little bit more to bed down. So it did bed down, I think, during April, May, June time, and I think it's round about that time that she then demits from that.
So one of the things that happens, I'm not asking you to comment on this because it's just context to bring the story forward, is that Dr. Inkster has described how after she arrives, she is written to by the infectious disease consultants, and indeed a number of other things are sort of bubbling around her head, and she discovers by receiving an email from Mr. Parry about the general ventilation. I wonder if we can look at that. So that is an email of 26th of May 2016, which is bundle 20, document 68, page 1495. Now this email is not sent to you, but it's an email from Mr. Parry to Dr. Inkster and Shiona Frew, copied to David Loudon, Anne Harkness, and Mr. Walsh. And we've looked at it with some of those witnesses, and we've seen that it sets out documentations that to some extent explain why there was a variation in the general ventilation. Now, this is the 26th of May. I wondered when you learnt that the general ventilation in the hospital was not 6 air changes an hour, but was 40 litres a second.
20th of June 2016. So water went down the wrong way. 20th of June 2016.
And how did you find out?
What happened was I got an SBAR, and there had been an outbreak of, I think it was mycobacterium abscessus in one of the, I think it was level 7.
In the cystic fibrosis ward. It's a rather long SBAR.
Yeah. So I got an SBAR and basically said, we're going to close doors and we're going to put these measures in place. And what I realised from the beginning of the SBAR, it said something about air changes. I didn't know about air changes. I didn't know there was that was an issue. But when I read it, I thought, oh gosh, is this an issue? And I then emailed back. I actually had also spoken to the chief exec, and I've actually emailed him separately about it. And in that email, I did say I think there should be a systematic review.
Could this be bundle? I'll come back to systematic review in a moment, if you don't mind. Okay. Bundle 4, document 11, page 52. Is this the SBAR you're talking about? 52, please. 52? Yes. Is this the S-bar you're looking at?
Yes, so it was a strange thing because it was an S-bar which was about the infection control measures, but when I read it, so it seemed to me it was about, this is what we do, and it was for the staff. When I read it, there was the background bit, which I thought, oh, wait a minute. So it was the reduced air changes to 3. I didn't actually know that you were supposed to have 6, but it was reduced to 3.
Right, so you asked for a systematic review.
No, I didn't. So what happened?
I must have misheard. Sorry, I thought you said that.
Yeah. So what happened is I remember this very clearly. I emailed back to the team. So it was David Loudon, Anne Harkness, and Teresa, and I emailed back to say, this seems to be an issue. I didn't know whether it was or not. This seems to be an issue to me. Can we all meet urgently to discuss this? And I do remember I felt a bit as though, and I also spoke to the board chief executive. I must have spoken to that day because I then emailed him at 10:30 at night. And that's when I said, there seems to be a couple of issues here. There's the air changes issue, and I knew about the negative pressure rooms, I think, at that point. I think I did. And therefore, I said, should there be a systematic process? I wasn't looking, I didn't know what I was looking for, but what I was trying to say was, should be a systematic process because there's now been issues raised with me, and I've got that. So what happened was I then spoke to Teresa because I wanted to know, and I think I said, should we get, is there an impact on patient safety? And I remember what Teresa said to me to this day. What she said was that the measures that she had put in place would address the problem, and that that this was engineering-wise very difficult to unpick, and you would have to rebuild the hospital if that was the case. And therefore, that these measures would be appropriate. And indeed, I think they did work. And so I kind of got the impression that there had been a change somewhere down the line. And I think the other thing that David Loudon was asked to do was go away and look at where this change came from. So I had then spoken to the chief exec. I actually spoke to the director of nursing as well. I'd forwarded it to him. I told him all about this, and I kind of felt as though I'd maybe overreacted because everybody was saying, well, that's what it is. And we weren't seeing any infections in the hospital. We weren't seeing that. And so therefore I was accepting the advice that was given. But I remember it was the 20th of June.
So one of the things I challenged Dr. Inkster about when we asked her about this was, do you see how the recommendations are at the bottom of the page? And I put it to her that recommendations, because she mentioned that these had got into SOPs. Now, we've not looked at the SOPs, but she explained that effectively, I think she accepted that 2 to 7 will have made their way into SOPs to some extent, because they're the sort of things you can put into an SOP. So you can say, for example, number 3, when you do an aerosol generating procedure, there should be 2 hours left between patients in the inpatient setting. You can do that, and that's what her evidence was. But I pressed her on the first one. Doors to rooms should remain closed. I don't understand how you could have a risk reduction measure of doors to rooms should remain closed without telling the people who've got to shut the doors why they're doing it. Because doors are often left open in hospitals. People like to hear the noise of the corridor, at the very least. Do you appreciate that there might be an issue with, this is a bunch of risk mitigations that Dr. Inkster has suggested, but the first one only really works if people know why they're doing it. And the board never really talked about this problem at the time, did they?
So again, this looked as though there was an operational issue being put in place for these wards, and that those steps were being taken. And that the air change was the air change, and unless, that was my understanding of it. In terms of, and it might be going off the point a little bit here, but in terms of the CF patients and the mycobacterium abscesses, what I did do, and I can't exactly remember when, was we took all of there was a debate around that, and it was more around the CF patients at that point. There was a debate around the mycobacterium abscesses internally within GGC, and we can we can come to that because it was quite a contentious debate. And what happened was I then sent all of our data, I think it was Brian Jones, and we wrote to HPS and we asked them to look at it because it was quite a new bug. I wasn't...
They produced an SBAR eventually.
Well, what happened was that they got the respiratory clinicians together from across Scotland, and they then decided that that I got an email back from Laura Imrie saying that they weren't going to take it forward, and I can't remember all the details of it, but it had been looked at by the clinicians because, and they were taking infection control precautions on that. So we could dig out the emails on that, I'm not absolutely sure, but I had actually written, I think, to HPS at the time to say, is every other hospital got this? Because CF, or not every other, CF was only... There are adult services, which I think were ourselves in Edinburgh and Aberdeen, because you need to be specialists in those specialist children's services. So what we wanted to know was, what was this new bug? What were other hospitals experiencing, and what did we need to do about it? And that work took place over the ensuing couple of years, I think. And we got something back from Laura Imrie saying, and I've got some of the trail around that with respiratory doctors coming back saying, well, this is, I don't want to actually speculate because I need to go back and look at it. But anyway, we did escalate it, we did ask for advice, and we did get advice back from HPS, and it involved the other centres in Scotland.
Thank you. Now, we'll ask Mr. Loudon about what he then did when you asked him to look into this.
Well, he did come back with an email.
Did he?
Yeah. I think you've seen it before. It was about the dialysis points or something like that.
Oh, yes.
He did come
No,
back with
I'll look at that over the
can
coffee
show
break.
it to you.
But in terms of the context, we have an email, which you've not seen. It'll be in your bundle from the day, but I don't think you got it, from Mr. Seaborn on the 23rd of June. That's bundle 12, document 104, page 813. Bundle 12, document 104, page 813. That's the 23rd of June, 2016. Now, I'm confident that you didn't receive this email at the time. It's not sent to you, and you're shaking your head. I just wondered whether it's quite a detailed email. Did you get any detailed response from Mr. Loudon to explain the air change rate derogation from him at the time?
So again, Mr. Loudon was on the same level as me. He reported direct to Robert Calderwood as well. And therefore, I had shared it already. And there was an email which was about 30 emails down about when this decision had been made. And I would have expected him to, he's not reporting to me to tell me about the derogation. So, and in those days, wasn't really sure what derogations were, that these were done by the estates team. So I haven't seen this email before. I'm not quite sure what's precipitated it, but...
Because it occurs to me that your inquiry to Mr. Loudon might be what precipitated it. But if you, and you point out that Mr. Loudon doesn't report to you, you're at the same level, but I just wonder whether you received a substantive response from him about why this derogation had happened. And if you didn't, that's fine.
It was the only thing was that he in one of the sets of emails, I need to go back and check it, in that June of that year, there was an email way down. So there was two emails, and I can't remember exactly. There was one email, which was from, slightly different, was from Public Health in 2011 about the negative pressure rooms, which they had actually gone back to gone back to the team in 2011 saying we're going to have negative pressure rooms. The second one was around that email that I've seen now in the public inquiry, when I went and dug it out, and that was the email around the dialysis points, and it's
I'll find that over the coffee break.
So that was the only thing I had, and I passed all that over,
right,
and I didn't.
So the final question I want to just check is I want to connect a piece of your evidence with a piece of Professor Steele's evidence. So I asked Professor Steele whether there'd been any formal risk assessment of the ventilation derogation, and he says there's nothing apart from the documentation that is attached to Mr. Parry's email. You're nodding. And you've obviously seen Dr. Inkster's SBAR and you've acted on it in the way you've described. And I wondered if you're aware of any other document that could, even with a stretch, be described as a risk assessment other than that SBAR carried out in respect to the general ventilation issue.
Nope.
Now, I want to just quickly move on to the work to the adult BMT ward. I want to look at the final options appraisal in March 2017, Bundle 27, Volume 7, Document 6, page 158. Now, before we get to this, you have mentioned there has been a process, and we've heard evidence about the process. We've got documentary evidence about the process, about the health board deciding what to do about Ward 4B. And the options are being considered, and there's a series of reports, and we've asked people who've been involved in them about what happened. And we've got I think, quite a good chronology of the events that get us to March 17, which brings us to this option paper. Now, you're a member of the Acute Services Committee?
Yes.
Yeah. And I'm not going to ask you to pick the options or assess the differences, because this options paper then results in work, and ultimately the patients move back in 2018. I want to ask you about something that is set out in it, which is on page... Sorry, carry on.
Yes. So can I just very briefly, and it's just very briefly, because actually this is not the paper that went to the Acute Services Committee, and I can tell you why. So what happens in 2016, and I'm just going to very quickly go through that because it is pertinent to the inquiry. So in 2016, as you know, we've then got HPS. We've set up that group, which is led by a manager, and we've got HPS, we've got infection control, we've got the clinicians, and we've got estates. At that point, the clinicians actually write to me, and they say in 2016, we wish to go back to the Queen Elizabeth, and they give their reasons, and I think this is important, because what was happening at that point was, although they were at the beats, and although the environment may be optimal, up to, and by the time we got here, it was 46 patients. Patients were being taken out of their isolation room, because when you give chemotherapy, particularly with bone marrow transplant patients, they can get sick really quickly. So they would have to take the patients out, put them in the back of an ambulance,
and bring them to the Queen Elizabeth.
Queen Elizabeth, yeah. And then they would not be in isolation, but more than that, there would not be the clinical team who would look after them at the Queen Elizabeth. So that was deeply worrying. And if you look at, and you'll see some of it in this paper. And at that point, we tried to then get an agreement with HPS, with infection control, and the answer at that point was no.
Indeed, there's a whole later SBAR.
But just, if you just bear with me a little bit. So then what happens is, and it was fascinating listening to Sandra Devine's evidence, because I hadn't quite understood this. The clinicians come to me, and we are trying really hard. So we've got this team trying to look at all the options, and they say, can we go to the 11th floor in the Queen Elizabeth? That was a non-starter. We then get I can't remember the name of the company to then do, and I'm not involved at this point because I've handed it back over to the team. So what happens is there's then, throughout 2016, from the autumn of 2016, there is then a company that do an appraisal. And what they say is, can we move it to maternity, can we move it to neurology? Yeah. Because we're not sitting at the Beatson with no risk to the patients.
No, I understand
There's considerable risk. So and I'm not involved in that, but I've got an overview now. So in the December of 2016, back comes the report, and the report says, I think neurology and maternity are out. So we're back to whether it's Queen Elizabeth or whether it is going to be the Beatson. Now, they do an option appraisal, and this is what this relates to. And the option appraisal we do all the time in the NHS, but it's not quite the right way of doing this. So the option appraisal says, what's the clinical impact, what's the infection control impact, all this. And then what happens is I get this paper, because I remember it very clearly, because they're now coming back to me, and the clinicians are saying, there is patients who may come to harm unless we get back to QE. And you've got HPS and infection control saying, we don't agree because we've got it. So you've got a really difficult situation on your hands. Now, if you go to the end of this paper, what you'll see is at the very last, so I'm reading through it, and at the very last paragraph, it says that we want to go back to the back to Queen Elizabeth, and this overrides the advice of infection control and HPS. And at that point, I'm thinking, oh, no, we can't do that. So what happens on the 16th of March, I get a group of people together because on the one hand, you've got, and that's back to what I said, patient safety it's a sliding scale. It's about the groups of the teams you've got there. So what happens is I get everyone into a room, and we all learned from bringing patients in 2015. So what we then agreed to do is, this paper I think says the patients will go back to the QE. And so I felt uncomfortable about that. We all did. And what we agree to do, and this relates to HPS thing later on, we agree that we are going to do up the bathrooms or whatever it is, and that's that big scribe debate that you've been debating, and that we will start monitoring the air. And only if the air is of a decent quality will we then take, because you've got one side of a risk, you know the clinical risk, but you don't have the other side of the risk. So this paper is changed. I take it to the Acute Services Committee, and what I'm looking for there is, I'm looking for money basically, and what I'm saying to them is, I cannot give you certainty about the groups, the patients going back. I can't. On the other hand, we've got to do this work, and we've got to make sure. So what happens then is that goes forward. The scribe gets, and we can debate that as well, gets delayed. It then goes back to HPS, I think in October of 2017. And what we say to HPS is two things. One is exactly what does good look like in terms of the particle. Now, I'm not involved in this. I've handed it back to the teams. And the second thing we're saying is how exactly do you want us to measure it? That's the HPS thing that you've shown. So what then happens is they start doing that. So they do the work and they start monitoring and monitoring and monitoring. And I'm not exactly au fait with all the issues around air changes. What I can say to you is, once the monitoring takes place, and again, I'm happy to talk about what happens in 2018, because in March of 2018, what you see, and I think you've got it somewhere, is the HPS and infection control and the clinicians all say the monitoring is appropriate. We had a wee blip, a wee shimmy around about April, May time, because I'm trying to get a new service in there called CAR-T. But that's beside the point. So what happens in March and May of 2018 is the monitoring starts to look really good. There was a shimmy in March, and then in May 2018, HPS are all there. Actually see that the monitoring looks good. And then there is another paper, which actually is the paper that pulls all together. So what they say is, here is what Ward 4B is in Queen Elizabeth. Here is all of the co-located services. And here is the air monitoring, because you have to do it for quite a long time. And then it goes back at the end of June of 2018. Now, what I can say to you, because sometimes I think it's a bit missing in this, it's not optimum, I know that. But we go right, I went round the ward the other week. We do 75 to 80 bone marrow transplants a year now. We have a very low infection rate. And I think the other thing to say is that when it went back, the clinicians and I then put a bid in for a thing called CAR-T. CAR-T is a life-saving therapy, but it makes you very sick. And there's no way we could have done that to the Beatson. So what they said to me when I saw them about 3 or 4 weeks ago was they believe it's exactly the right decision. So the reason for telling that long story is because it's not just about, is it 6, 7 or 8 or 9 air changes? It's about a whole risk assessment. And in the end of the day, what you're trying to do is to provide a decent service for the patients. And I believe we've done that.
It's very helpful, Dr. Armstrong, because the question I wanted to put to you, well, there were two of them. And the preliminary one is just to note something in passing, because I think it appears to be acknowledgement of a fact, which you've put into context, but it's still a fact, potentially. And that's on page 172. So if we look on page 172, and I absolutely accept this is a report that didn't end up going to the committee, and I absolutely accept that there is a balancing exercise, and you just explained it in great detail and extremely cogently, the nature of these balancing exercises. But do you see how at this point, within that balancing structure, the author of this report is accepting in the first paragraph that 4B at that point didn't meet the standard set out in the guidance?
Yes.
And that the children's ward didn't either? In the next paragraph. Currently, the BMT unit in the children's hospital doesn't meet the standard either. However, positively, the rooms do have a positive pressure of 10 PA HEPA filtration and have anti-rooms. Do you see that?
Yes, I see it.
Now, the question I want to ask you is this, and actually your explanation just given is very helpful to put this in context, is you've explained the large amount of work and difficult decisions that were required to address, those two facts, in essence, and the balancing exercise that had to be carried out to take account of the clinical risk and the environmental unknown risk. Would you not accept that if the hospital had been built to these standards and procured to those standards, as is set out, I think, in the tender documentation, then you wouldn't have had to do any of this. All that stress and aggravation that you've just described, the difficult decisions that people had to make about balancing risk, would not have been needed because the facility would have been built in compliance with the standard and the issue would never have arisen. Would you accept that?
I would accept that if what we thought we were getting had, so I don't know all the standards.
No, I'm sorry.
But after having lived through it and having kept patients safe at the same time when you're trying to actually make these decisions, and the decisions are made by multidisciplinary teams based on a risk assessment, and that will happen in the NHS, and it will happen, and it will continue to happen because treatment advances go on and you have to make decisions. But if somebody had handed a hospital over, then it would have been so much better and so much easier because we had to do a lot of this while we were treating patients. And patients, the only thing I would say is the overriding thing for us was the patients. That was it. And therefore you had to make these judgments because it's easy just to have one side say, right, just don't do anything.
You said that.
And then the other side says, so it's about the patient and getting the best risk balance you can address.
Well, I think this is probably, at my lord, an ideal time to have our coffee break, 15 minutes.
We'll do that. And could I ask you to be back for 10 to 12?
Okay, thank you.
Like that.
Mr. McIntosh.
Thank you. Thank you, Dr. Armstrong. Before we move on, I think I might have found the email which you were discussing that comes from Mr. Loudon, but I'll want to just put it to you and see whether I'm right. Could we look at bundle 12, document 105 at page 815? Now, to be fair, this top of this email, it's not sent to you, but it's sent to Mr. Loudon, and I wonder whether any of this is ringing a bell with you. So you see there's an email, 22nd of June, the bottom half of the page, from Mr. Ross of Curry and Brown, explaining how the derogation came about. Is this something you would have been forwarded to you?
No, it wasn't forwarded. The one I'm thinking of, I think you've already discussed it in the inquiry. I think you discussed it with Peter Hoffman, I think.
Right, well, we'll have another look. My colleagues next door will react and keep hunting. What I want to do is move on, if that's off the screen, to the events that occur when Dr. Inkster goes off on sick leave because of her lymphoma. And in what way did her absence on sick leave affect the IPC team in the in the Queen Elizabeth Hospital?
I think that from memory, Dr. Inkster went off on sick leave quite suddenly.
Yes.
And it was something like the 13th or 14th of June.
2017.
2017, yeah. And she did carry a lot of sessions, and I think that that had quite an impact on the team because she was doing a lot of sessions in infection control, and that's not easy to backfill. So I think that had an impact, undoubtedly. And that's with all clinical services. In the NHS, you don't have lots of spare capacity, and therefore it did cause an impact.
I want to look at something that happened while she was off sick about 6 weeks later, which is bundle 14, document 69, page 696, which is an email to you from Dr. Peters. So it's a long email, and I wonder if you could look on the screen. Do you remember receiving this response, this exchange with Dr. Peters?
Yes, I think there had been an earlier email.
There is. If you go up on to page 700, we see the bottom of the first email from Dr. Peters. We go back to 699 and onwards to 698. We see an email from her on the 23rd of August, 2017, and then we see a reply from you, top of that page, at 698, and over the page on 697, we get her, and you reply on the 3rd of September 17, and she replies back to you.
Yep.
Now, what I want to just is check a few things that I understand we're talking about, what we're talking about. So these should be quick questions. So in essence, the subject of this email is about the approval of work to 4B in Dr. Inkster's absence. That's right.
Correct.
Yes. And Dr. Peters gave evidence that she emailed you because she'd raised it with Professor Jones, and he'd told her to email you if she had concerns. And then you respond with a detailed answer in which you say she should raise future issues through appropriate channels.
Yep.
Is that roughly right?
That's what's in the email.
Yeah. Now, you, I think, have noted in your statement that Dr. Peters stopped works going ahead.
Yes.
Was that an appropriate thing to do at that time, as far as you're concerned?
I think that so maybe just putting it into context, no, I don't, but if I can give a bit of context in that. So around about June of that year, so I've already taken you up to the point where the Acute Services Committee meets in, I think, March.
When the draft paper we looked at was being thought about.
And what happens there is that we all agree, Acute Services Committee agree, that there needs to be work carried out in Ward 4B. And Dr. Inkster is also part of that decision-making process. At that point, she goes off sick round about the 13th or 14th of June, whatever it happens to be. And there is then an email, which I actually have from David Loudon, which he forwards it to me because I'm keen the work goes ahead. Because, in fact, the board's keen. And the reason we're keen is because we know that there are issues with the patient staying.
Which you've described.
Yes. So what happens then is that Ian Power, who've met, decent guy, he then puts the scribe out with, I think, Lynn Pritchard. I only know this, I wouldn't know this level of detail, but we're keen to go ahead. At that point, they're then wanting the work to go ahead. Now, I'm not quite sure, but I heard the evidence of Sandra Devine that Dr. A had said that that's okay. So what I then found out, and I found this out very recently because it's actually in your bundle, so the way it would happen, and I actually get that email and I forward it on to Tom Walsh, because Tom Walsh is the manager. He's the general manager whom Dr. Inkster reports into, and that's important.
Dr. Peters?
No, Dr. Inkster reports into Tom Walsh. So when you go off sick, what happens is you're supposed to say to your manager, or your manager's supposed to say, Jennifer's going off sick, here's the portfolio of work that she's got. And then with Brian Jones, Professor Jones, they then look at that portfolio of work and then...
So why is it Professor Jones? Is that because he's the microbiology lead?
No, Professor Jones had very kindly came across from the Royal to cover. So what I'm trying to say...
So was he the lead ICD?
He was stepping into Theresa Inkster's unfilled space.
But he was effectively the lead ICD?
Yeah, he was acting that.
Right,
But my point is, so I'm just trying to see where I think this all went wrong. And this is actually only recently when I actually looked at this. So what happens is, if you were following management things, what should have happened, and I actually forwarded the email from Ian Powery to Tom Walsh about the 25th of June. I was just looking at it, 2017. And what I say to Tom is, Tom, here is a piece of work that needs to be done by somebody. And he's saying, yes, absolutely. But then Dr. Inkster actually emails Dr. Peters. Now, Dr. Peters is not Dr. Inkster's line manager. And that's actually, I've got it, it's in your bundles. Which if you've got it there, we can have a look at it, because I only discovered this. So what happens is it's emailed on the 21st of August. And in that email, it looks like we've got the old version of the bone marrow transplant discussion. Remember I said at the end of 2016, there was all of this debate about whether we could go back. So from what I'm looking at your bundle, like I've got the bundle reference if you want it. What happens is she then forwards that on the 21st of August to Dr. Peters. So rather than the line management structure being it's then forwarded, and it's actually an old version, which looks like it's saying is the one, and I can give you the bundle reference on the 16th of November 2016, which was the one in which we were having real problems getting the BMT. It doesn't reflect what actually the Acute Services Committee says. That's then forwarded to Dr. Peters, who goes back to her and says, please be assured that you've handed over valuable information and so forth. That then goes into, I think, the 21st of August meeting, which they're trying to get the scribe forward, and then it's stopped. Now,
But just a moment, before we go on, let me just check something.
Yeah.
The information that we have, some evidence, some written, is that the reason it stopped is that these clinicians, these ICD session doctors, don't think they have enough information to sign it off. That's their professional judgment. Are you disputing that their professional judgment is wrong at the time, given the information they had?
No, I'm not disputing that. So that's the bit that that's what I said with Sandra Devine's evidence. I don't know enough about that bit, because what Sandra Devine seemed to say was that Dr. A had said in an email, it's okay if Lynn's comments are taking place. So that's the bit I'm a bit uncertain about. But it certainly stopped on the 21st of August. And the problem is that the emails are coming from left field into this. Now, what should have happened is that should have gone to the management team, who then can say, this is the piece of work that requires to be done, who's going to do it, and what support do they need. But what happens eventually, and you'll see it in my 3rd of September response, is that Professor Jones, who is an expert in these matters, was actually very, very good. He stepped into the breach to sign off the high scribe, so that work can take place, so that we can do the monitoring, so that we can get the patients back. My point is, if things are passed between people without a formality, then things start to go wrong, rather than going to the general manager who's got responsibility for that service. And that's where I thought, and when I saw the email in the bundle that made a lot more sense to me because I hadn't seen it before.
So is this in fact not the same issue that is being mentioned in Dr. Stewart's review of infection control back in 2015? One of the issues is that he's been told that some ICDs are not making decisions that they've been given the power to make. Are we basically dealing with a scenario where at this point something's gone awry in the infection control team, and it's the same fundamental management issues that have been around for 2 years?
What I'm trying to describe is a bit similar to that, but slightly nuanced. What I was trying to do is piece together what happened here, because I've been aware of this for a while. And in the public, when I was looking at my own bundles, I found this just by chance. I then realised, so what happens is when you've got parallel lines of communication going on, then things go wrong. Because rather than it going up through the management chain, so the manager then says, Brian or whoever it happens to be, here is what we need done, here is what happened in the past, and also giving a consultant, particularly a young consultant, some help and some support. But what happens here is different. There is communication going on that they are not aware of, which is giving the wrong information from what I can see, and I can do the bundle because I've got it here. It gives the wrong information.
So what bundle is it?
It's bundle 4, I feel a bit awkward saying this, but...
Bundle 14, volume 1.
Bundle 14, volume 1, page 582.
Let me get it on my page. I'll just look at it first.
There it is. So I don't know if the Melanie McColgan one's attached to that email or if that's separate, but if it is attached to that email, what you'll see there is that's the 6 months out of date from what we did in March 2017, because at the end of 2016, and you'll see that advised that is unlikely to provide a long-term solution for BMT. That's what that says. And what I'm trying to describe to you is a multidisciplinary process which weighed up the evidence in 2017. So if that was attached, then I can understand why there was a lot of confusion.
So you would understand that the response of Dr. Peters and Witness 7 to that email would be to not sign it off. You appreciate that?
If that's the case, and I'm speculating here because I don't know if that was attached, but if I was in, say, Dr. Peters' position, and I'm getting that, I would look at the first line there and say, unlikely to provide a long-term solution for BMT. And therefore, I'm speculating, I don't know, but it was quite interesting because it happens at exactly the time when they all met on the 21st of August.
Okay, let's take that off the screen and just wrap this up with a single question. You've described just now, based on looking at your bundles in the last few days, your suggestion about why this went wrong. I just want to check that's right. You've given an explanation about why this went wrong. You'd accept that?
I tried in my own mind to think through what happened. And this was an additional piece of evidence which might make the picture fuller.
But is there not a similarity between these events in August 17, and the events in late 15, when Dr. Inkster is asked to sign something off? And this is what I want to suggest to you, that the management structure that's operating in the infection prevention control team is not ensuring that information is passed around, that people are being asked to make decisions with either the wrong or limited information. Now, we can have a conversation about whose fault that is in terms of providing the information, but will you accept that people are being asked to make decisions on base either wrong or limited information?
I think that if we go back to the 2015 issue that you've just described, my understanding of that is that there had been a piece of work taken forward by Professor Williams and the contractor. I think what happens is that Dr. Inkster becomes the regional ICD
I think she'd been that for some years, but keep going.
But yeah, so she comes into that role and she looks at the work that's been done and she says, I don't think this is going to pass muster, which is absolutely her right to do, absolutely her right to do. There is also evidence, I think, that shows that there was a lack of information being given from the time the hospital opened, and I think you've described that, which is from the estates, the validation side, that all of these things that people need. I think the management team of infection control, had they had that information, would have been very happy to give it over, but it wasn't their information to give, if you see what I mean. So I think with this particular issue, because it didn't go through the proper management structure, and there's a calm, thoughtful way of doing it, that there was information coming from left field, which was not then being put forward, which made that difficult. So SMT do give information.
The question to resolve this is, if there's been a repeated example of information not being given or not being noticed or the wrong information being given, was there something wrong with the management structure operating in infection prevention control at that time?
I think what I'm trying to say to you is that the infection control team that we had, I don't recognise that, because what I saw was that they had senior management team meetings, a lot of them are minuted, and you've got a lot of these in the bundle. We sent them to you. We've got an acute infection control and a board infection control team, and there's a lot of information being given there. The question, I suppose, that I've been grappling with is, could there have been a better way in which that information was then cascaded into different clinical communities? And there was, I think, a microbiology leads meeting. And could there have been a better way in which there was a regular information flow going to them? But I wouldn't accept the senior management team or indeed the infection control team were withholding information or not giving information. They were giving the information. It's really around, in a big system like GGC or indeed in any health board, how you make sure that people get the information that they require in a much more systematic way. And I would accept that, I think, in terms of that could have been improved.
Right. Well, I want to leave the topic of Ward 4B now by asking a couple of brief questions. So, patients eventually returned to Ward 4B from the Beatson in June 2018. Was the ward ever accredited by JACIE?
JC, yes.
And when was that?
It was, I think it was May of 2020.
Okay, thank you. Now, the next question is, patients returned to Ward 2A in 2022. Did NHS Assure offer to review, assess, accredit, or any of Assure even, the work done to Ward 2A?
I wasn't involved in that process, but I'm sure that we could provide you with that information. I just don't know that.
Are there currently any outstanding issues with water leaks, mould, or ventilation faults in any of the specialist ventilation wards, 2A, 2B, 4B, 4C, 5C, and 5D?
I don't have that information, but again, we can provide you with that. It's not sort of information that I would routinely.
Now, I want to move on to the stage 1 whistleblower. Now, you receive a series of emails from Dr. Redding, which is on holiday. You wait till she replies. You ask for an S-bar. Let's look at the S-bar. Not to go through it in detail, but to ask just some broad concepts. Bundle 4, document 20, page 104. Which of the issues in the S-bar were you not already aware of or were new to you?
That is a good question. I'm trying to put myself back in time, and that's quite difficult because I'm kind of reading this a lot.
Because I'm just wondering at a very broad level, would you accept that there are quite a lot of things, not necessarily all of them, not necessarily very few, but quite a lot of things that were probably news to you at the time?
I wouldn't say quite a lot, but there's bound to be something there. If you go through it, I did want them to write it down. I wanted to see it all.
And would you accept that at the time the 3 whistleblowers were acting on their duty, the duties they hold under good medical practice to advise people of problems that they think they can see.
I think that,
We can take that off the screen.
yes, so I think that I didn't mind them writing to me. I've got a pretty open door policy. So for me, yes, I think there were other ways in which it could have been dealt with before it reached me. But I want things, I asked for them to write it down so that I could systematically address it.
Okay. There's some series of things that were given in evidence by Dr. Redding and Dr. Peters about the meeting on the 4th of October. I need to put them to you. So the first one is Dr. Redding described the meeting as difficult, and she felt intimidated by the large number of people who were there. How do you respond to that?
I think that coming into a meeting like that probably could be, because I had got, what I wanted to do was, I think I heard one of the cases, I suppose what I wanted to do was I wanted to get the directors, because a lot of these things are not in my bailiwick, but I wanted to make sure that we were taking it seriously. And therefore, I can see that coming in, and I heard some of the evidence that was given, that might appear that way, but it was not in any way conducted in that fashion.
Okay.
And I walked out with Dr. Redding, and I remember it because it was in the QE and the TLC, I think it was. I walked out with her at the end of the meeting, and it was a pretty decent exchange.
So Dr. Peters gave evidence that you said at the beginning that all comments should be addressed through the chair. Did you do that?
No, what I was trying to do was, because I was aware that there had been sort of interpersonal issues between some of the participants, what I did set out at the beginning was the GMC Code of Conduct. And therefore, I was trying to get people to be respectful. And I don't recall discussing it through the chair. Maybe I did say that, I don't know, but the meeting was not like that. It was a free-flowing meeting with people talking to each other.
Dr. Peters gave direct evidence here a few weeks ago that when she introduced herself at the beginning of the meeting as head of department at Queen Elizabeth University Hospital Microbiology, you responded, "You're the head of nothing. Brian is the head of service," just to be clear. Did you say that?
No, it's Dr. Peters, not Dr. Redding. So no,
Sorry, Dr. Peters.
So I have just set out that this is a GM. I'm using the word GMC because all doctors understand that. So I'm trying to set out a professional. I wanted it to be professional. I wanted to my mind, I wanted to walk out of that room having addressed, or not even addressed, but having understood all the issues, documented them, and then I was going to really run with them.
Did you, at the end of the meeting, have any concerns about the behaviour of anyone who was there?
No.
So an action plan's produced, 27-point action plan. To what extent did the action plan set out actions that were not already being carried out by the board?
From memory, I think a lot of them were already being carried out by the board. I just need to, I can't remember.
Well, let's put it on the screen. Bundle 20, document 48, page 792. Again, I don't want to
go through it
line by line, but all I'm in a sense putting to you is that bundle 20, document 48, page 792. That's not bundle. No, I've got the wrong place. Yes, it is. Sorry, 3 pages on. There we are. I don't want to go line by line. I don't think that's necessary. It just, am I right in thinking that there will be stuff in here that is to be acted on by the board that wasn't being acted on the board before the SBAR?
There's not that many. Just quickly. So I think the front page we're pretty much doing. Yeah, you can go to 12 now. I've read that. So I think most of that page we were doing, and then yeah, they raised some decent points. But some of them, it's not actions; it's actually increased number of line infections. We were doing that.
So in broad terms, they were raising.
Yeah, we were doing most of it, but I think they were right to mention a lot of it. I had no problem with that.
To what extent might it be the case that many of the things they were raising, because they were microbiologists, they simply wouldn't know about because they weren't in the management structure that was addressing them in the way you've just described this morning?
I think that's a good point, because I think that they had a lead microbiology meeting, and that was the point I was reflecting on when I looked back and I had a look at the minutes of that meeting. Dr. Inkster attended some of them, but not all of them. And I did wonder. I wonder if we should have created a report, because in order for committees to function, you've got to create a product that goes routinely to them. And I did think, was that missed opportunity? Should we have created a regular report rather than them having to ask about it?
So at this point, it's late 2017. Was 5 sessions a week enough for the lead ICD for Greater Glasgow and Greater Glasgow's Health Board at this point?
Again, I think the operational team were managing that, so I wasn't in detailed being involved with that. I think that a lot of the work of the new build contributed that, and we see that coming on.
But I'm asking you as medical director, because you're the professional lead. Do you think it's enough?
What I was getting advised by the team was that the sessional commitment was fine. I think that with the additional work of the new build, whether or not we could have increased those sessions, possibly yes. But I do think...
And so Dr. Redding has made the point that she might have been reassured if someone had sat down with them and taken them through what was being done in the action plan in the months after this was produced. And that she might not even needed to make the stage 2 whistleblower. She just actually had information about what was being done. How do you react to that?
I think there are, in 2 ways. The first way I would say is that I could have got the action plan to them sooner. I think that's correct. However, what I would say is that there were, and I was just looking at it last night, there was a series of something like 28 emails that went between, even in just me alone, between the late October through to February, because we were giving updates. There was 3 big emails, one in November, one in the January, where Ian Powrie comes in and gives a huge amount of information on the ventilation within the Queen Elizabeth. And then there's one when Dr. Inkster comes back, which is the patient placement policy in February. So there was a lot of email traffic going on, but I think we could have done better in terms of providing a decent report. And we waited for Dr. Inkster to come back because it was pressurised, Brian Jones is stepping into the breach. And she came back and she shared, and I think she did the right thing. It was something like the 13th of March, because I was copied in 2018 with I don't know, it was with Dr. Peters and Dr. Redding. And we probably could have done that earlier. I probably should have done it in December.
Right. Let's move on to the events in 2018. You've covered the water incident in some detail in your statement. And just from our own notes later, it's question 203 from page 219 to 225, and quite a lot of detail. And you've described how you receive an email from Dr. Inkster on the 1st of March 2018 at the time of the Beast from the East storm. You've said that you had no concerns about the water supply before that date. I wondered if I could simply put this to you. There had been a series of IMTs around bits of the water supply, like the aseptic pharmacy, in previous years before then. Had you not heard of them, or were they not presented to you as being a wider issue?
So the way that I would normally hear about, so there's not an informal way, but there's a way in which I would meet with the infection control team, and I met with them regularly because it was a significant focus for me, and they would tell me about infections. The other way, which is the more formal way, is that the amber and reds here would come up through so not all infections, but the ones in which there were IMTs or whatever would come to the Board Infection Control Committee, or I would be aware of something, and sometimes I'll there's an example of that in 2017 when I will look very closely at something because I'm worried about it. But no, I think that I wouldn't have, some of them were PAGs, so I think that aseptic pharmacy was actually a PAG, which I wouldn't have been aware of. And I'm also assured by the work that was being done by the infection control team to test the water when it was required. So and there was nothing coming up to me that said, look, we've got a lot of these infections and there are positive water samples. Not at all.
So from your point of view as medical director, what is the system in the health board that is doing the job, because I appreciate it's not your job, of ensuring that the water system, domestic water system, is safe or is at least not being managed in a manner that's high risk for, say, Legionella and Pseudomonas? What's the system that's doing that?
I think that, again, that's not in my remit. That would be something which the Director of Estates would be better, so Tom Steele would be better at addressing that question, because I'm the medical director, so I don't know all the details, but I know there's been a huge amount of work done by GGC to improve the system.
No, but I'm thinking back at this point, because we've seen the water safety plan, and we have the water safety group co-chaired by the director of facilities and the infection control manager. So I'm wondering what information you're getting from the infection control manager about Pseudomonas, given your responsibility as HI executive lead.
Yeah, I mean, I think that a lot of these things would be done by, if there was an exception report. There was a Pseudomonas risk assessment that came to the BICC, but a lot of these areas would be on the, if there was something abnormal, somebody would have told me, but I didn't get routine reports from the water group, but there was, I think, a Pseudomonas risk assessment that was signed off by infection control estates and the lead nurse, I think.
I wonder if we can look at two documents. One, just to put it in context, I'm not going to ask you more than one question about it, which is the water incident debrief meeting on the 15th of May 2018. That's bundle 14, volume 2, page 211. Now, do you remember this meeting?
I don't see I'm there.
Well, in that case, I'm not going to ask you about that. I'll ask you about the second document, which is a report that came from it, seemingly. Bundle 27, volume 5, document 19, page 46. This is drafted by Dr. Inkster and seemingly sent to everyone who attended the meeting. I wonder if you remember seeing this document.
If I attended it and she sent it to me, fine, but I probably don't. I don't remember seeing it, but I must have seen it.
Because the reason I'm asking you is this question is, you go to the next page, we see a discussion of the type of the incident and the idea of a contaminated water supply. And all I wanted to ask you is this, is if we go back to the end of May 2018, if I'd come to you and said, Dr. Armstrong, is there currently some suspicion of a contaminated water supply in the hospital? How would you have reacted?
I think at that time, and I think Dr. Inks is right in this, at that time I was absolutely, yeah, there's something in the water. It was particularly around when there was the middle of March, yes. I mean, I felt at that point, because what I was being advised of was that was the case. The thing that I remember most was that concern with the patients. That was kind of dry, because water is like everything. So so therefore that was where we were coming from, was what do we need to do quickly to make sure the patients are safe. So yeah, I bought into the what was being said.
Do you now have any issue with the suggestion that there was the water system was contaminated?
I think it would be better for you to, I think it would be better for you to address that question to other people with greater expertise than me, because I think I don't have the expertise to really address that.
Do you now have a view, based on what you know now, as to whether there is a connection of any sort between the infections that were being seen in Ward 2A in the first 8 months of 2018, any of them, and the water supply?
So the position, I think, of the board.
I get the position of the board.
Yeah.
It's your position.
So yeah, I think at the time we all believed it, and we all put in measures to do that. But with the evidence that we've got now, and that I think you heard with the whole genome sequencing for a number of the organisms, but not all, then it would seem to us that we haven't made the connection between whatever was in the water and what was in the patient. And in some of the bugs, we've got whole genome sequencing for that, which would make it less likely. And in some of the instances, we don't have that. But when you look at how did it get into the patient, what's the portal of entry, then it's uncertain as to how that occurred. And I guess the position would be, the question would be, is the environment more risky than any other environment in any other hospital in the UK? And we have not found evidence to say that.
So you'd like to see comparisons with, say, Leeds or Great Ormond Street or Oxford or Cardiff and the Vale, for example, to see what their infection rates are?
If you look, well, again, there's the broader issue of the broader environment. But again, if you look at the minutes, in March of 2018, we got an email from HPS saying we're going to do a bit of work.
I realise that, but I'm asking you a question.
What I'm saying to you is, I was very, very keen in 2018 that we needed to look at other units in the UK.
Right, so would you be interested to know what the comparison is between Ward 2A in 2018 and the equivalent wards in other tertiary centres across England and Wales? Would that be a piece of information that would help you understand the issue? Right. Because we'll come back to the epidemiology towards the end, because I want to wrap it all up in one series of questions. It seems more efficient in time. But what I wanted to do now was to ask you about a particular point that Dr. Inkster made. And I don't think it fully came across in a statement, but it came across in oral evidence. And that was the idea that she says, she put this to you in the early part of 2018, that there should be some form of executive control group to parallel the work of the IMT, and in some sense for it to report to them. Because, as she put it, she's only the chair of the IMT. She can't make big decisions about resources. Now, do you remember that conversation with her?
I don't, but I do have emails around that.
Do you think that would have helped?
Yes, I think that I am. So the email trail I've got is us setting up that executive group. And I think I was emailing the Chief Operating Officer to say that, and also that Dr. Inkster would be a member of that. That's the email trail I've got. I do believe that when you have long IMTs with lots of actions, lots of resources, and lots of things that need done, to put all that stress onto the IMTs not helpful. And in fact, if you look in the guidance, it says that actually that's good practice. So yes. So
was the group set up?
I believe it was, but I'm not sure how effective it was. There was a group where Kevin Hill was because I found some emails, I can't really remember it, where he actually would give us an update on things. But I'm not sure how effective
Because even if it wasn't set up, was there in effect something similar in that at various points we're going to get to from now on, things that are thought by the IMT to be a good idea, such as fitting chlorine dioxide, are taken forward by executive bits of the board? Is that something that effectively happened?
The fitting chlorine dioxide, I think that was the water technical group that did that. I think that was set up at the end of March. And so things like that's a huge engineering feat. So of course that's going to be taken off. But I didn't attend the water technical group, but what I understand was that they oversaw that, but it was a significant engineering feat that would be certainly not expecting the IMT to do that.
Because one of the things I'm trying to get from you, and I've not quite got it, is that if it was a good idea to have an executive control group, presumably it would have been a good idea for you to be on it and for the IMT chair to be there to report to it. And I don't think you're saying it actually happened in that format.
So I'm talking about something different then.
Yeah.
So what I'm talking about is.
But I want to know whether the thing that you talked about happened. Was it set up?
So the thing that I was talking about was Kevin Hill updating me in the Chief Operating Officer. That's not what I'm talking about. So what I'm talking about, and I'm not sure it happened effectively, is you need operational management, not people like me, but operational managers to take the actions that are required to progress to do stuff. And therefore, if you take that away from, so the IMT says we need whatever they need, and then the operational management team goes ahead and does it. I think that's a much more effective way than trying to get 10 teams to then do it and you're trying to coordinate it all.
But there wasn't a meeting set up on the basis that you and Dr. Inks discussed where you and she and the operational people would be in the same room and it would make the decisions.
No, that was not what I discussed with her, I don't think.
So I must have misunderstood. So I
Yeah,
thought
yeah.
you said
So
that.
I need to go back and check. No, that I would not have been on that type of group at all. It would not have been me to go on that group with lots of operational managers, because again, the governance structure, I come in and advise people and get involved, but the governance of the operational management team goes up through the regional directorate up to the chief operating officer.
So if you're having some form of executive scrutiny of the work of an IMT in terms of ensuring that its operational consequences happen, wouldn't that need to involve someone like the medical director to bring a clinician's point of view at a senior level to these decisions?
So if there was a need, that would be really, I think, taken forward by the operational management teams.
But they're not clinicians.
Well, the clinician part comes in the IMT. The operational management team, so I can describe this, and I didn't really do it particularly well at the beginning of the NHS in Scotland has a general management function. So the general manager will lead, so like I report into the chief exec and the nurse. So that goes all the way down the organisation, and the governance route, and that's really important for patient safety, for money and for staffing. So the for the acute sector is a 2.1 billion budget, 21,000 staff. That's with the chief operating officer. And then it goes down through the regional route, or women and children. We've got 6 divisions, and that governance is very strong. So that needs to, so for example, just to give you an idea, if they needed some capital, for example, then that needs to go through their capital group, because you've got a certain amount of capital, but you don't have unlimited amount of capital.
I understand that. But
so it wouldn't be appropriate for me to sit on an acute.
Okay, well, we'll come back to that in a moment. Let's just pick up an issue on the way past, which is the emergence of the DMA Canyon report. Now, you described in quite clear terms how you felt when you found out about it.
Yeah.
And Dr. Inkster has described in quite clear terms how she felt out when you told her about it and what she did and how she had to go and get a copy and all that. That's all been described, and I don't think there's any real dispute about the detail. But one of the things that she has said in her evidence is that she felt a measure of disquiet, that she would have been sitting, in her case, in water safety group meetings, but also in meetings around the IMT, with the very people who might well have known about the DMA Canyon reports. And she feels they should have told her. Had you been sitting in meetings with people who should have known about the DMA Canyon reports and didn't tell you?
Not that I'm aware of.
So you would never have had meetings about when water came up with Mr. Gallagher or Mr. Parry or Mr. Loudon?
I don't think I would be in meetings about water with any of that group of people. I might have been in an IMT, can't remember if I was in any of the IMT. I probably was, actually. So I would have been in an IMT, I think in March. I think I was in March.
So it would have been rare from your point of view?
Well, I would go, yes, it's rare for me to go to the IMT, and it's usually at the request of the clinicians or the chair.
Okay. So I want to ask one question which slightly threw me, and maybe I'm just misunderstanding. You explained in your statement that you hadn't read the DMA Canyon reports from 2015, 2017. Is that right?
Yes.
You produced a presentation to the board about them on the 3rd of July, 2018. Are you really telling us you hadn't read them?
So I always think as medical director, you've got to be really careful that you don't assume an expertise that you don't have, because then people start listening to you and you don't have that expertise. So the DMA Canyon report, it does stick in my mind to this day. The chief executive called me to her office and the reports were there. Now, I have not got the expertise to understand what the report says, but I do know when I do have the expertise to know when things are relevant. What I gave to the board the next day is nothing about the actual
well, let's
report.
Look at it. It's bundle 27, volume 8.
We found it.
Page 58. So that's the header. Let's look at the second page. This is your presentation. You see the second bullet point?
Yeah.
And that comes from the IMT, I think. And over the page, the priorities. Are you, and you see it says the bottom of page 59, external contractor reports from 15 and 17 identified recently with considerations around implementation. And you're clear you didn't read the reports when you made this presentation.
No, what we're trying to do then, I actually can't remember this meeting, but I found this presentation, so I wanted to give over. I think at that point we had, so I had been talking to the board about the infections, and I had been reporting through the hair, and I knew the board, and I can't exactly remember who said we should do this presentation, but what we're trying to do, it's a board seminar, is make board members aware that this was an issue. I'm not going through the detail of the report because I wouldn't be the right person to do it, but what we were saying to them is we find this report and we go on to set up. Sorry.
I want to just clarify something now about the decant of Ward 2A in September 2018. Now, we've obviously had evidence at this hearing and at the last hearing, particularly from Mr. Redfern, about his options paper. So we know about the different options and we know the difficulty of the decision, and I'm not wanting to ask you about that. What I want to do is simply to understand something that seems to be missing from your statement.
Yes.
Who was it who made the decision to decant the Schahalian patients from Ward 2A to ultimately a ward in the main building?
So what I gave you in my statement was minutes of a meeting on the 14th of September.
Yes.
Yep. So what happens is that when you have a decision of that magnitude, then it is perfectly proper that the IMT members, and you see on the 14th of September.
So this is page 250 of your statement.
Yeah, sorry.
And there's a full executive meeting on the 14th. We've had evidence about that.
I've given you the minutes of it, if you've got them.
Yeah, I have. I don't need to look at them. But
Okay, so what happens there from looking at the minute is senior members of the IMT come and they meet senior members of the executive team, and they then set out their rationale as to why they think this should happen. Now, what they're looking for is the executive team to approve that decision.
And indeed, at that meeting on the 14th, they don't actually approve it, do they?
I was thinking about this because in my bundle there's then a meeting on the 17th or whatever it is, which I can't remember at all, but I've gone back to.
Well, there's an IMT. The reason I'm trying to cut this short because there's a simple question to ask. You have the meeting on the 14th,
yeah,
and on the Monday, the IMT on the 17th, it's reported that the executive team haven't actually made the decision. And there's some talk about getting a drainage report done. I'm not going to ask you about that. And then there's an IMT on the 18th. And what there's also is a meeting that's missing from your statement. So this is bundle 19, document 34, page 614. And I wonder if I can show it to you. It's in your document list. Can you help me? We've had some evidence, not from people, well, we had evidence from Mr. Walsh, who didn't really remember it, but it's reported, it seems to be reported by Kevin Hill to the IMT when the IMT meets about 2 hours later. But what is this minute of?
Yeah, I cannot remember this at all, but I was obviously there. So I went back and asked what was the water review meeting, first of all. And what the water review meeting was a twice weekly meeting, which I was not at. And that was to look at the DMA Canyon report, I think. We seem to have joined this meeting on Tuesday, the 18th of September, because it's only appearing in my diary once. And we've discussed it with that. My memory of it, and it's a bit vague, and you're right, we're a wee bit vague on this, is that we actually had made the decision, I think, by the end of that Friday the 14th, because it was the afternoon after the IMT, and that we realised, because if someone comes into you and says, the ward is unsafe, we need to decant, then the executive team are going to do that. What the 14th says is that Jane Grant was chief exec and she's very experienced. She wanted the risk assessment, I think, and some reassurance about that. But you're right, in this, it looks as though in page 2, there's a lot of discussion and debate. In the end of the day, I actually sent an email to Jane on the 18th of September because I read the minutes and I was concerned because at that point, Brenda Gibson says, I'm in London, I hope people with expertise, and I knew we'd made the decision by that point. So I'd emailed Jane.
Well, but had you? Let's look at the IMT minute.
Yeah, we pretty much had.
For the 17th, which is bundle 1, document 39, page 169. So this is an IMT which you are not present at. But if
That's
we
the
go
annual, yeah.
on to the bottom of page 7171, we see a report back from Kevin Hill from the executive meeting on the Friday, which is the 14th. And do you see how it's giving consideration of the options, which is Jamie Redfern's report? The executive group will wait until drainage expert will give a preliminary scope on how to carry out their work and see what they find. And then Ms. Dodd describes her concerns, and she's given evidence about that concern. So it's clear the IMT were told on the 17th that the decision had not been made on the 14th. So what I'm wanting to check is there any reason for the inquiry not to conclude that the decision to decant the ward was made at an executive level on the 20th in the water review meeting?
I can't remember the detail and it's fuzzy. I thought we'd made it on the 14th, but I can't be definite about that. I know that there is an email trail between myself and Jane because she's come back on the 18th. And what I've said there is we better let the IMT know, because I'd read the minutes and I'd seen Dr. Gibson's comment. And what I say is they seem to not realise that we've made the decision. We better make sure that they know. And Grant Archibald then goes to the meeting on the 19th of September.
On the 18th, actually.
Oh, sorry. No,
So it's the 18th, yes.
no,
on
it's
the
the
18th.
19th because
It's on the 18th. Bundle, same bundle. If we jump onto page 175, again, you're not present. And then we go on to the next, onto page 177.
it's there. You're right.
7, Grant Archibald informed group. So what I want to just check, because I appreciate you don't remember, but we need to get this right, is that on the 14th, there's an IMT. It's followed up by a meeting in which there is some discussion, but no decision is made. On the 17th, that is reported to the IMT. The morning of the 18th, a decision is made, and that is then reported to the IMT on the 18th. Does that sound right?
It sounds right, but I can't confirm that. I had in my head that we made it after but you've got evidence that suggests otherwise.
Because the point overall, I suppose, to take from it, the very high level point, is that this is an example of, because of the knock-on consequences, I mean, the patients who had to go, I think, to Gart Naval from
Yes.
the site, from 6A, the decision to decant couldn't actually be made by the IMT chair. It had to be made by an executive group because it's a significant decision for the health board.
So what I would say is that you're right. We were approving the decision that came from the IMT, and you're absolutely right. The IMT could not do that. What they said to us was it has to be in the adult acute. We went through, if you go through Jamie.
We remember the discussion, yes.
Yeah. So we were really interested to know, right, where do you want to go with this? And the view from memory was that they wanted 4B for the nutrient transplant children, 3 or 4 beds, and then the other ward had to be somewhere within the tower of the Queen Elizabeth. And we then tasked Anne Hartness, who is the director of the South, to find a ward, which is not easy to do that. And then it was back to the IMT. And what you'll find is in the board meeting that follows this, I report, because we wanted it public, that the IMT had given advice to the executive team, and the executive team had accepted that advice.
The important point, the one I suppose I'm labouring to get to, is that whilst in the end, on the 18th, the IMT, the executive team in the water review meeting did accept that advice and take that decision, it didn't initially do so on the 14th, did it?
I thought it did.
But the minutes suggest it might not.
But you're right, I can't defend that because the minutes suggest that. But I was pretty convinced by that point that we were heading towards a decant.
Okay. So yes, I think you probably answered that question already. So before we move on to the rest of the year, at this point, because it's going to become important, unfortunately, how would you assess your working relationship between you and Dr. Inkster in the autumn of 2018?
I thought it was reasonable.
Was there any, from her point of view, did you see any pressure points with the way she was working, or the burden of work, or the sort of work she was doing? Thinking back how you thought at the time.
No.
Let's move on to the early months of 2019. Now, I want to look at an IMT which you weren't at, and it's an unminuted meeting, but I'm going to put the IMT up on the screen just so we can have something to look at while we talk. So the IMT of the 18th of January, 2019, which is bundle 1, document 61, page 274. So this is the 7th Cryptococcus IMT. Now, for context, Dr. Armstrong, this is the IMT that approves a short-term decant from Ward 6A to the CDU, the Clinical Decision Unit. Do you remember that happening?
Yes.
Right. And I've had some evidence about this, and I need to sort of try and put it to you to see if you can help me out, because there's some differences. So we've had evidence that there's a meeting either later that day or a few days later, there's some uncertainty, in the ward or near the ward, at which present is, perhaps unusually, the chief executive. She's come over to have a look. You, Mr. Best, Professor Walsh, Sandra Devine, sorry, not Professor Walsh, Mr. Walsh, Sandra Devine, and possibly Professor Steele and Dr. Inkster. Do you have any memory of such a visit by Ms. Grant to the ward?
I've got a memory of that meeting, yeah.
Right. So what's happened at the IMT is there's been a debate, and you can see it in the minutes, where some people on this sort of state side, I think possibly supported by some of the infection control nurses, it's not quite clear, are of the view that certain building works to rooms can go ahead while the ward is occupied because there are various mitigations that can be put in place. And that's one thing that seems to have happened at the IMT. And there is a view taken by Dr. Inkster, which is perhaps that, no, that's not safe. We need to get out of the ward while this is happening. Now, in that context, what do you remember the discussion being at the meeting with the chief executive about that decision?
I don't remember that degree of granularity. What I do remember is that the chief executive quite properly wants to walk the patch, and to understand what's happening, and and often as an executive you do that. You don't sit up in your office when things are, you just don't do that. You go down and look at things, and that was what I think was happening. I don't remember all the debate about patients coming, where the patients. I suppose from that point of view, what we were trying to do was see what is the best thing that we can do for the young patients, and where should we put them. And there was debate around additional 4B, but I can't really remember it. But what I do remember was I thought it was a reasonable meeting where you had senior managers who have got experience asking questions, and that's what they need to do. And then at the end of it, I think, support Teresa in her view, but I don't remember it being. I just don't remember any more than that.
Well, that's very helpful. I now want to move on to the Cryptococcus cases in the winter of 1819, and I've got 4 questions and then some later ones. I think you've already sort of told me what the answer is going to be to this, but was there a particular reason that you attended the 3rd Cryptococcus IMT on the 16th of January? Because it's the first one you attend. It's bundle 1, document 58, page 261. I just wonder why that would be the one you attended. And if there's no particular reason, that's fine. But
yeah, just let me just think about this.
So it's about 3 meetings in.
I think it was the Wednesday. I think it relates to that Wednesday 9th. So yeah, I remember this. I don't remember the meeting, but I'm looking at that, and that's what's triggering me there. So what happened was the week before that, I had looked at the IMT minutes, first of all, on the Monday, the 7th of January, and I was anxious about a couple of things. And at the same time, I think Brenda Gibson emailed me because she was extremely anxious as well. And sometimes this does happen because you've got to sometimes do this. I had asked for a meeting on Wednesday, the 9th of January. I went down. And I thought at that point the Dr. Inkster was there, but she'd gone on holiday. So she chaired the IMT on the Monday, but she'd gone on holiday. And what was making me anxious was that, and I didn't have the experience of this, but was making me anxious was, one, the clinicians were anxious. Two, there was things in the minutes that I didn't quite like. And so I asked for the infection control team, and there was 2 infection control doctors there, plus, I can't remember exactly, clinicians and all the rest of it. And I did wonder about HEPA filters at that point, because I thought, gosh. Now, I remember early in the morning asking Tom Steele, can we get HEPA filters? Because in the minutes on the Monday, it talked about that. And I thought, well, why can't we just deploy them? And what he said to me was, we've got, I can't remember how many, but we've got a lot of HEPA filters because we'd already moved them for 4B. So 4B broke down. We had this big stack of, I'm putting it in a...
You had a number of them in storage?
Yes. So I pulled together a meeting on Wednesday, the 9th of January, and I make sure that there's infection control people there, because it's not appropriate for me to do it. And Jen Rogers was there, and there was people in the ward there, and at that point we thought, just deploy them. Now, it's out with the IMT, I get that, but we just thought...
So this is you effectively coming along to almost report back that you've done that and why, if it...
Yeah, so at that point there was debate about air sampling, about that. And again, I don't know that, but if you've got the minutes of that, there was a big debate about where you put the HEPA filters. Now, I'm pretty much out of my comfort zone, but what I am thinking about is I need to make an intervention. And it was out of the IMT focus. So I think I went along to that because I'm thinking in my own mind, I've got to provide continuity so that these people understand what we've done last week.
That's helpful. Now, soon after this meeting, I think the expert subgroup is set up. And you've mentioned that in your statement. Dr. Inkster's position is that in a sense, it was her idea because she wanted not so much to find out whether there was a link between the building and the infections, but to make sure that nothing had been missed in terms of taking steps to mitigate any risk that did exist. What's your recollection of why the subgroup was set up?
Yeah, I've got a reasonably clear recollection of this. So it was the end of January, the board infection control, something like the 29th of January, something like that. And we were discussing this. And there's a doctor there who's extremely experienced, and he's a consultant in infectious diseases, and he's very, very experienced. And as we are talking about the cases, what he says is, I don't want to give away too many patient details, but anyway, we talked about the cases and we talked about previous, where they'd been. And he then said, do you not think it could be sporadic reactivation? Now, I knew about, I'd been a physician before, so I knew about reactivation. And the thing about the Queen Elizabeth is, because it's so big, and there's 3 teaching hospitals, that you will get, I mean, what the deanery often say to me is that young doctors get very good training there because they see lots of rare things. Because you've got, if we had 2 cryptococcus, one in the Western and one in the Royal, nobody would have batted an eyelid, but we had this. So he mentioned that, and I thought, oh, right. And he said, are we sure this is not a reactivation? Because reactivation is far commoner than what was on offer. So at that point, I think we agreed as a committee, and I was quite keen on that we get an expert group set up, because what you've got to know the answer to this, because to give you an idea, there's 435,000 patients a year that go into that campus. It's huge. It's one of the biggest hospitals in the UK. So I was more of so we set it up, and we set it up initially with an infectious disease consultant to plus the technical side. And I think the technical side went on so long that they stopped coming, but that was the reason for setting.
And the infectious disease consultant was?
It was Dr. Seaton.
But he didn't end up staying on the group?
I think he gave his opinion, but because they were, and he's got a busy clinical job, I think he went for a few meetings and gave his opinion, but it was all about technical and airflow and all the rest of it.
Right. Now, one of the things that seems to have happened, and the question, of course, is live is whether it mattered. But one of the things that seems to have happened is that some highly immunocompromised patients were being accommodated in un-HEPA filtered rooms without being able to be given, because of their conditions, prophylactic antimicrobial medication. And to what extent do you have any concern that that happened, in that you had such patients in non-HEPA filtered spaces, when, had they been in 2A, they would have possibly been in 10 air changes, 10 positive pressure, HEPA filtered isolation rooms?
Yeah. I think that's quite a difficult question. I think, from what I can tell, and I probably wasn't aware of all this at the time, to be honest, because I didn't need to be in a way, but what I can gather is that there are groups of patients who require what I would call the BMT rooms. So that's HEPA filtered rooms. And then the old York Hill, and indeed across GGC and other places, that there are groups of patients who are accommodated in a normal ward environment. And they could be neutropenic. And that seemed to have been a practice that was, we would have that in hospitals. But I think it's a good question, and I don't know the answer to it. And I've watched that being debated, is what level of do you need, and what groups of patients should be in what level of environment? And I can't really answer that because I don't have the wherewithal to do that.
Because the question, I suppose, without going to the document which you're not familiar with, is SHTMO 301 2009 Appendix 1 contains a ventilation specification for what is described as a neutropenic ward. It's not a neutropenic room. You presumably know that now.
Yeah.
Yeah. And so, had the word neutropenic ward been interpreted as the whole ward, and we have had discussion about what to do about the dirty cleaning areas and the kitchen and so on, had it the whole ward been HEPA filtered and 10 air changes an hour and 10 positive pressure to the rest of the hospital, then there is a viewpoint that the patients would have been more greatly protected, because there would have been an additional barrier between them and any external air. And so, do you feel that there's any issue about the risks that patients might have been exposed to because the hospital wasn't built in such a way that neutropenic wards are interpreted as being the whole ward?
I think that's a pretty complex question that I'm not sure I can answer. I never heard the term neutropenic ward. I've heard of bone marrow transplant rooms, and then there was the normal ward. And that I understand was in place at York Hill, and then I understand was in place at the new hospital. I'm not sure whether or not, I think people more expert than me need to grapple with that question and answer it. I think clinical practice is changing. When I talked to the adult hemato-oncologist a couple of weeks ago, what they described to me was something I'd never heard of before. They described doing outpatient bone marrow transplants because of the antifungals were so good now. And they talked about that neutropenic patients can sometimes be treated at home, and I hadn't heard of that. So I think there's a debate that needs to be had, which I'm not the person to lead evidence in the public inquiry about what are the risks. It's going back to that, what are the risks? What do we know? What's the evidence? And where's clinical practice going? And so...
Would it have helped if at any point since the hospital was opened, outside Ward 2A, there'd been a formal risk assessment of this issue?
Of
that issue?
Of the issue of what, sorry?
What you just described, about where practice is going and whether it's necessary to have a whole ward set up at these high standards or not? Do you feel that's something that should be assessed?
I think it's something that absolutely should be assessed. I'm not sure that I would go back in time and say, with what we knew then and what we know now, I think it should be assessed. I think that we have to engage, again, I go back to this book, clinicians, infection control in the States, and there has to be a balance in what we come up with, because how am I going to put this? If you look at our previous board papers, for example, in August, what you will see there is
Sorry, didn't you say a PICO unit?
no, previous board papers.
Sorry.
So it's okay. So if you look at the board papers, I'm just trying to put it in context here. We are putting forward the Institute for renewal. That's the biggest, 60% Scotland's served by it. It's got everything in it. And we know, and I think it's something closing on 800, 900 million, something like that. And then we've got, I think, called a radioisotope unit, which we need 20 million for. That's 60% Scotland. Now, the question that we need to think about is, we know that there's a certain amount of capital in Scotland to build things, but it's getting less. And we know, for example, when you're running the Institute, it's 1970s building, we need to mitigate that risk all the time. And therefore, there is a need for us to understand what is the best. There's the immunocompromised patients. We absolutely need to make sure they're safe. But actually, sitting on a witness stand, I can't give you an answer to that today, because it needs to be a balance of risk across a whole range of patients.
I suppose just before lunch, I suppose the only question to follow up with that is that not that pressure of funding that you're describing, not a reason for when you do spend £800 million on a new hospital, it's probably a good idea to build it in conformity to the guidance that does exist at the time, and to do that with your eyes open.
As I said before, that would have made, I just want the patients to have a good
What's
care.
your answer to the question I
Yeah,
asked?
I think if it would have avoided all of the issues that we had, that would have been fantastic, because the stress that the patients were put under, particularly the 2A patients, was enormous, and the parents. So absolutely, I think that we should have had that. I guess where you're coming from, though, is where I'm coming from is we need to look at the evidence. What is the evidence showing us? What does it translate into? And how does that then say how we should build hospitals in the future? What I'm saying to you is that if you look across Scotland, there is risks that all health boards run with all sorts of groups of patients. And what we need to do is balance up all those risks within the resources that we've got in order to ensure that. We have to do up wards of Glasgow Infirmary, for example, for patients. You know, there's a whole panoply of things that the public sector needs to look at. So I wouldn't jump straight into a conclusion there.
Okay, well, I think it's probably a good idea to break for lunch at this point.
Just a small matter of detail. Did I hear you correctly, rather, when you said that you hadn't, prior to the involvement in the inquiry, come across the expression neutropenic ward?
Yeah.
Or you said that?
Yes, I said that.
Right,
I hadn't come
thank
across
you.
it.
And what I take from that is that an experienced doctor, albeit not a specialist in the area, does not recognize that as a generally understood term.
Yeah, I wouldn't take me as a benchmark, because I'm probably not experienced, but I've never heard anyone talk about neutropenic ward.
Right. Well, thank you. Thank you. We will take the break, and can I ask you to be back for 2 o'clock?
Yes, of course.
Thank you.
Thank you, Melissa.
Exactly.